Good morning to all respected dignitary, participants, staffs of Mobility India, faculty, and my dear students. Today we have organized CRE program on recent trends in management of spinal deformity. And this program is accredited by Rehabilitation Council of India and organized in collaboration with ICRC. So we are very privileged to have our all speaker with us today, and they are all experts in their own respective fields and have extensive knowledge and experience in dealing spinal cases and management. They will share with us their insight and tips on how to provide optimal care for a patient with various intervention. So to begin our day, I like to invite our beloved Executive Director of Mobility India, Alvina Shankar, to welcome the members.
Good morning to everybody here. It's a lovely morning in Bangalore, and it's a pleasure for me to welcome all of you for this program, which is continued education for the professionals. Firstly, I would like to give a warm welcome to Navid on behalf of all of us here as well as the board. Thank you very much, Navid. Navid is from ICRC for people who do not know. Thank you very much for supporting us and for being with us all through. And I think it's your passion as well to ensure that how we can build the capacity of the professionals ongoing. Thank you, Navid, and welcome to Charu as well from ICRC. Thank you very much. Thank you, Dr. Prashant. Thank you. It was lovely meeting him because he's an pediatric orthopedic surgeon. So he really understands the need for early intervention, which is a very, very important. Anything that we do early intervention is very good, very useful, so that children with disabilities do not have severe disabilities later on as well. So thank you, Dr. Prashant, for being with us today and agreeing to be a part of this as well. Dr. Arjun, thank you very much for being with us. I know it was a very short notice, so thank you for being a part of us. And I'm sure your inputs would really help the students to understand what it is and from the government perspective as well. Thank you very much. And of course, Dr. Mayura, thank you very much for being with us. I think we have the experts in the field who would actually share what is it and how important it is for early intervention, and also having a multidisciplinary approach to any treatment, which is very, very important in the healthcare sector. So there are a lot of PNOs, physiotherapists, and the doctors here. So Mobility India strongly believes that it's got to be a multidisciplinary approach for any intervention. So thank you for being with us and sharing your knowledge. Yes, not last but the least, I think I would like to welcome all my staff, colleagues, my students. I hope this is going to be a very learning for all of you, for you to take it forward in the coming years, in the near future, and in your lives as well. So welcome, and I'm wishing this program all the success. Thank you very much. Thanks, Rajdeep.
Okay, so without further delay, let's start our program. So next we have light lamping, and now I request dignitary Mr. Navid Dadwin, Regional Physical Rehabilitation Project Manager, ICRC New Delhi, Dr. Dr. Prashant Inna, Orthopedic Surgeon, Manipal Hospital, Bangalore, and Dr. Arjun from Manipal Hospital, and then Dr. Mayura, Clinical Physiotherapist, Physio for You, And then our academic and technical director, Ms. Ritu Ghosh, come forward and join for lamp lighting. And also request Mr. Sanjay and Ms. Minachi to join for the lamp lighting.
आरोग्यं धनसम्पदा सुखं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परं ब्रह्म दीपज्योतिर्जनम् दीपज्योतिर्परं Velastam Samaya Velastam Samaya Yavatsuryodayo Yasya Deepa Tasya Nasti Daridrata Shubham Kurutvam Kalyanam Arogyam Dhanasampada Shubham Kurutvam Kalyanam आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा.
Thank you all dignitary. So next, now I will request Mr. Navid Dadwin to address the gathering. He is a regional physical rehabilitation project manager, New Delhi. He has been working for the ICRC since 2011 in various countries such as South Sudan, Tajikistan, China, Myanmar, and presently working in India since 2022. He has also worked with a person with physical and mental disability and elderly for various organizations in Iran for almost 8 years. So I'll request and we welcome Mr. Navid to address the gathering.
Thank you and good morning to all of you. Great to see so many colleagues, I can say. I'm a physiotherapist as well. So in this hall for this topic, I wanted to talk about the importance of a topic, but it's clear with your interest and attendance to all of us that how important it is. So to ICRC, we had this long collaboration with Mobility India, and I'm thankful for all the kind words to all of my colleagues. And this is not the first time, I think, with Mobility India, we have the topic of spinal orthotics. In 2019, we also had a hands-on clinic here for 5 days. And last year also, we had one webinar on spinal orthotics and the new current method. So great that there is a continuation on this because of the importance of it. So, and today is multidisciplinary, thanks to both of the doctors, the surgeons that you're here. What Albina said, I want to also repeat that, how important it is to work as a team, physiotherapists, prosthetists, orthotists, surgeons, and the patients. That's very important. So without them, because we are talking about corrective devices. So if they do not contribute to our program, to our interventions, we will not succeed. So important for all of us to remember and to bring them on board, and how important it is that they do, if it's about exercise, it's about how to use the device, and their families. So I don't want to take more of your time. It's great. Let us start. We will be with you also throughout the course to learn as well and to refresh. So wish you all great day and best. Thank you.
Thank you, Mr. Navid. I'd like to call Navid on stage. Yeah. I'll request Alvina ma'am, Executive Director of Mobility India, to come on the stage to present the memento to Mr. Navid. Can you call Asma quickly?
Can I ask
Yeah.
one question just out of curiosity? Can I see how many physios are in the room? Okay, and how many piano? Majority. And there are doctors with us as well? 2 doctors with us. Okay, great to know the dynamic of the room. Thanks.
Okay, so I apologize for that. Okay, so we'll start our main session. And if you'll see, the topic of today's first presentation is pediatric scoliosis and management. So dear participants, it is now time to begin the first session for the CRE program. We are very honored and privileged to have our first speaker with us today, Dr. Prashant Inna. He is a pediatric orthopedic surgeon in Manipal Hospital, Bangalore. During the academic period, he has received many gold medals in MBBS. He is associated with Indian Orthopedic Association, Indian Federation of Sports Medicine, and National Academy of Medicine Science, India. He has presented many papers in various conferences, many publications have done, and he is the author of many articles and books. And he is actively involved in research activity, and he is awarded with the best paper presentation under 40 years of age. So, okay. And the title of the paper is The Giant Cell Tumors. Please put hands together and welcome our first speaker, Dr. Prashant Inna.
So good morning, everyone. Thanks for this wonderful opportunity. So I think I'll be presenting a surgeon's perspective on the deformity management. I would not be going too deep because the audience is not surgeons. Yes. Can you see it? Thank you. So today I'll be talking on pediatric scoliosis. Predominantly, I'll be focusing on the idiopathic variety, which is the commonest variety of scoliosis. Just a minute. Can I have a marker, a pointer? Do I have a pointer? by any chance? Yeah. So while I'm talking, you can just give it. Yeah. I'll be focusing on the definition, etiology types, the principal X-ray and the MRI that we need in scoliosis, and the treatment in brief, predominantly from a surgeon's perspective. So what is scoliosis? Any lateral deviation of the curve. So either a right bending or the left bending is scoliosis. But how do you officially define it? It is defined as greater than 10 degrees of lateral deviation from the central axis. Although the definition says it's only deviation in one plane, it's in actuality a deviation in 3 planes. So it's a 3-dimensional deformity, and the rotation is the predominant component in scoliosis. Now, there is a common thing that people call it as kyphoscoliosis. It is wrong, because most of the time the scoliosis does not cause kyphosis. It actually reverses the kyphosis. It flattens the curve in the particular plane. So it should not be called kyphoscoliosis, only give its name scoliosis. It's reasonably common. Thanks. It's reasonably common, around 1.9 to 3% in the 12 to 14 years age group, and it predominantly affects females. The commonest cause that we identify is called idiopathic, which means there is no cause. But the structure in the body which is supposed to be affected in the idiopathic variety is either calmodulin or elastin. The other 2 common causes are neuromuscular and congenital. Neuromuscular means there is weakness of the muscles, because of which the spine cannot stay straight. In congenital, you have so many defects in the shape or the number of the bones. So either the shape is defective or the number of bones are defective. So if there is a defect in the shape or the number of the bones of the back, then they can have scoliosis, and that one is called congenital scoliosis. So how do you classify idiopathic scoliosis? The commonest thing is called James classification, based on the age at which the scoliosis makes its appearance. So infantile, when the appearance is less than 3 years, juvenile, when the appearance is 3 to 10, and adolescent, when the scoliosis begins after 10 years. The issue is we should be particular about the age of onset. That is more important in India because they do not come as soon as the disease is detected. So the age to which it presents to you is not important. Age at which it starts in the baby is more important. Why? Because they have prognostic significance. Which age it starts tells us how it is going to behave in future. The other common way of classification that we surgeons use is called Lenkes classification. It has 3 variables, complex, and the other one is based on the location of the curve, whether it's in the cervical, cervicothoracic, thoracic, all the way up to the sacrum. So where exactly the curve is. What to ask? Being a doctor, yes, what to ask and what does the patient complain to you when they come to you with scoliosis. So predominantly the symptoms will be about asymmetry about the shoulders. So shoulders are not at same level, the waist are not at same level, or the rib cage looks different, or they can have a rib cage deformity, bend, or breast asymmetry in a female. You have to ask for family history because predominantly it runs in families. Important question to ask is about the physiologic maturity, because we want to tell the patient how it is going to behave in future. Is it going to get worse? Is it going to stay like this? Or is it going to improve, which is very unlikely. But for that you need, when did the baby sexually mature? Why did I say menarche? Because it is predominant in females. Presence or absence of pain has to be inquired. 25% people have it. And when a person with scoliosis complains of pain, they are more likely to have problems. What are the problems that we suspect? Either a lysis or a listhesis. What is the meaning of lysis? If there is a break in the back portion of the spine, that's called lysis. And after the break, if there is a slip forward, that is called listhesis. A painful scoliosis typically has some issues with the back. Not necessarily these 2, but commonly these. How do you examine on a general basis? The commonest thing that we use for screening is called the Adams forward bending test. What is it? Make the child bend forward. If there is no scoliosis, or if the scoliosis is flexible, there is scoliosis, but the scoliosis is entirely flexible, the 2 ribs are at the same level. But if there is a scoliosis and there is a structural scoliosis, what is structural? There is a change in the shape of the bone, which is permanent. Then one of the rib humps will be higher, the other rib hump will be lower. The other thing that we see is shoulder unleveling. The shoulder will not be at the same level. The medial border of the scapula will be very prominent and the chest wall looks asymmetric. These are the common complaints with which they come, and you have to look for scoliosis in these symptoms. One of the common things is truncal shift. So what is it? Usually if there is a bend, there will be a compensatory bend and the body tries to keep the neck in line with the sacrum. Neck in line with the sacrum. But if there is no such compensation or compensation is inadequate, the neck will not be in line with the sacrum. So if you draw this line called the plumb line, the neck is away. So that's one of the important components that you have to see to look for the correctability of the scoliosis, which is very important for your orthotics and bracing. Again, in the examination, a basic neurological examination should be performed, including for the cerebellar signs. You have to look for a difference in limb lengths, either at the pelvis level, knee, or wherever, but that difference in limb length should be actively looked for. Yes, I'm not going deep into all these examinations because I think as orthotist, so much is what I feel is enough. In terms of investigation, X-ray of the whole spine is very important. Please note it's a whole spine X-ray. It should start from the top and bottom, preferably in a standing and preferably in a single film. So top to bottom in a single film. If you have to stitch the X-rays also, that's fine, but let it be in a single film. Important is right and left bending views. I'll show you why it is important. Corpse angle is very important because we keep telling about the angles. I said 10 degree, 20 degree, 25 degree. What is a degree? This degree is the corpse angle. How to measure, I'll tell you in the next slide. Bone age is very important, again, to predict the prognosis. Suppose if the person is very mature, the possibility of the scoliosis maturing, progressing or worsening is less. MRI, what is the use? I'll come back. Pulmonary function test is usually done in severe cases. So these are the general set of tests that we do in pediatric scoliosis. In the X-ray, if you see, it has to be always the whole spine, preferably standing. And this is the very important method called corpse angle. What is corpse angle? You want to know how bad the bend is. So you will see where the scoliosis is starting, where it is ending. So these two are called end vertebra, where the curve begins to start and where the curve begins to end and meets the midline. So you draw the horizontal line from there, draw perpendicular lines to those lines. So horizontal line from the lower end of the lower end vertebra, upper end of the upper end vertebra, perpendicular lines to these, and measure the angle. That is the corpse angle. That shows how bad the deformity is. And whenever we say 20 degree, 40 degree, we are telling about the corpse angle. Here comes the importance of the bending films. See, there is a bend in two planes. The moment there is a bending, this bend is straight. So this is called the compensatory bend. This is not the true bend. That is the true bend. This is to make sure that the body stays straight, the body compensates. So to distinguish which is the compensatory bend and which is the fixed bend, you need these bending films. So you need both right and left bending films to see. You should also notice that here the bend looks more, but the moment the bend is there, the bend doesn't look that bad. So this shows that even the primary curve or the basic curve is flexible. And that gives you the scope to put your bracing and correct it. So you are going to correct a flexible curve. You are not going to correct an inflexible curve. That is our job. So for you, these bending films will give this information whether the primary curve is flexible or not. MRI is not routinely done in scoliosis, but yes, it is required whenever the complaints are unusual. Someone has scoliosis and headache. You need to see something is missing there. So MRI is needed. Atypical clinical findings. They have severe kyphosis, syndromic features, they have neurological deficits, or you have infantile juvenile scoliosis when the curve exceeds too much. Baby is very small, very young, but the curve is very bad. Then you should suspect that something is wrong, or it is rapidly progressing. You see now, 1 year down the line, the curve has progressed by 10 degree, 15 degree. Then you should get an MRI to see if you are not missing anything. And suspicion of congenital scoliosis. So what is congenital scoliosis? The shape of the vertebra is different or the numbers are different. Means they can be fused. They can be fused in half portion. Only one portion might be there. The other portion is missing. Or you have two half portions. All these combinations are there in congenital scoliosis. Whenever you suspect these, you need to make sure that the spinal cord is okay. The MRI is being done not to see the bone defect. We can see that on X-ray. We do the MRI to see if underneath the bone there is some problem. So that is to rule out the spinal cord defects or the spinal covering defects. So myelomeningocele and all those things. Coming to the treatment, I put these pictures because that is what we will be doing in a different way. That is how oldie goldie started. Hippocrates started with pulling both the things from top and bottom, or you pull him down, push him down like this, vertically hang him, and then see whether the correction happens. So we all sort of draw our, basics or principles from these. So I put these two pictures. The basic treatment modality for scoliosis will be 3 O's. Observation, where you don't do anything. Orthotics or casting, about which you will be learning more. And operative intervention, which is predominantly ours. Now, when to choose each of these treatments is a complicated manner. It is not very simple, but broad guidelines are: if the curve, which is the corpse angle, is less than 25 degrees, they are preferentially observed and monitored with X-rays at regular intervals. So if the corpse angle is less than 25, you can observe, or you will preferably observe. If the corpse angle is between 25 to 40 degrees, you will preferably start bracing. Now, these are not hard and fast rules. You can consider bracing if the curve is more than 40 degrees, if the curve is flexible. I showed you how to look for the flexibility of the curve. So even if the curve is more, but the curve is flexible, you can still go for bracing. If the curve is less than 25 degrees, should you brace? Yes. You have to brace if it is less than 25, if it is rapidly progressive. So 25 to 40 is not a hard and fast rule. Less than 25, rapidly progressive, brace. More than 40, flexible, brace. More than 40, inflexible. If they're not flexible, then you preferably operate. So what do you do in scoliosis when you observe? So we have graded strengthening exercises to strengthen the muscles of the trunk. They are called physiotherapeutic scoliosis specific exercises. Obviously, Dr. Mayura will be dealing with it in more detail. So I'll not be focusing too much. It is predominantly used in younger kids and when the curve progression is slow. If you think the curve is progressing fast, you have to do something more. If you think the curve is progressing slow, you keep observing them every 6 months to 12 months. Keep taking the X-rays, keep taking the corpse angle, keep seeing how the curve is progressing. If it is slow, be happy and keep giving the conservative treatment. The exercises are very specific. They are individualized. You cannot be generalized. They should be performed regularly throughout the treatment. They can be done prior to, during, or during weaning of bracing also. And it can be done in post-operative period also to reduce pain. So physiotherapy is there throughout your course of treatment, throughout different varieties of treatment. Coming to braces or orthotics, this is how the old braces started. With all the metal things, it was introduced very long time back. In general, when the corpse are more than 25, corpse angle is more than 25, you give the braces. Usually, it's the conventional thoracolumbo-sacral orthosis. You have different Milwaukee type braces and the casting. The braces are more of maintenance. What do you mean by maintenance? If you already have developed a curve, the progression of the curve, further worsening of the curve is slowed down or prevented by the brace. So you are maintaining the curve there. Because if you give a brace and if the curve corrects, then probably that curve never required bracing. So there is a word that a curve that resolves in brace, it probably would have resolved without treatment. So brace usually does not correct. It usually maintains the correction. What are the broad guidelines? Each treating team provides the brace that they know best. So there is nothing which is very good. What is good in your hands is good. You are good at one thing, do that well. If you're not good at one thing, don't try unnecessary things. No particular brace can be recommended over others. Nothing which is very good. It is recommended to use the least invasive brace suitable for the clinical situation, provided the effectiveness is maintained. Because when you give a brace from top to bottom, particularly in a teenager, psychological impact is too much. So they don't like braces which are seen. So try to give the brace which is not seen or which is just seen or which can be masked by their clothes. And that ensures better patient compliance. Young child might apply, older child, it's difficult. It should not restrict thoracic excursion. If breathing is difficult in a brace, they don't like it. So please keep these things in mind. Obviously, I'm not a specialist in brace. I should not be telling you what to think, But as a surgeon, what I think should be done from your perspective is what I'm telling. The nitty-gritties of the bracing, you'll be taught later. Now, how long should the brace be worn every day? No less than 18 hours daily. So it should be at least 18 hours, because longer the bracing, better the success rate. But I think around 16 hours per day is fine, because more than 16 hours up to 23 hours is too taxing and compliance becomes a problem. So 16 hours is a fair enough ballpark. On an average, however, they wear only 65% of the times. So compliance is poor. And the organizer, just let me know if I'm exceeding the time. How many more minutes left? Just let me know. Yeah. And be open, no problem. So brace till when? It is usually recommended to be worn till the end of growth, till the end of skeletal maturity. And the weaning time then should be gradually reduced, not that you suddenly stop the brace. You wear it for so many time, the skeletal maturity happens, then you gradually cut it down, not that one fine day, up, end of story. There are many new varieties of brace. Spine core brace, which is multiple straps tightened, they have a good efficiency. You have the nighttime bracing, which also have good efficiency. And you have the post-operative bracing for pain relief, particularly when you have a doubt about hardware failure and the bone quality is very poor. Body cast, again, fond of history, because that is how it will be. It was done initially, and something similar will be done today afternoon, I think. Coming to surgery, it focuses on halting the curve progression. In surgery, basically, you have this rod. This straight rod maintains the straightness of the spine. This straight rod on both sides has to be fixed to the body. And to fix to the body, it utilizes different methods. So basically in surgery, if I have to simplify, a straight rod, 2 numbers are put to the spine and they are fixed to the spine by multitude of methods. What methods? You can have bands, you can have hooks like this, you can have pedicle screws, sublaminar wires, and many other things. So commonly what is used right now is pedicle screw. So screw goes into the body and rod is held by the side of the body. There are different varieties. You can fuse it from the front. That's called the anterior release or fusion or instrumentation. Instrumentation means you put the screw and fix. You can do it from the back. That's called posterior fusion. You can do growth modulation, wherein you put the rod, expand it, and gradually straighten it. Or if you do everything, this is for the correction of the spine. But most of the time, parents come with deformity in the chest wall. You have corrected the spine, but the chest wall looks similar, deformed. What do? You can do thoracoplasty. That is when you change the shape of the thorax for the sake of the cosmetic deformity. One common thing that used to happen before, no longer now, is called crankshaft phenomenon. If you only fix it from the back, the front growth will rotate the spine. If you fix it from the back, but don't fix it from the front, it will rotate the spine in future. So what do? You do the spinal procedure fusion also. No longer done. It's very uncommon nowadays. So anterior approach, it's usually through here or here. You go from the front, more risky. You have to sometimes open the thorax when you have to do that. Posterior approach is from the back, less risky. And you have the growth modulation procedures wherein you put the rod and you gradually straighten it out. Or you can use the front tether. You can just stop the growth of the front part by putting the screws on the front part of the body. Surgery has complications. The one thing we are very worried about is when there is nerve damage. When you do the surgery, after surgery, they become paralyzed is what we are worried about. There are many problems, yes, but we always try to keep them to minimum. Follow-up, around 10% of surgeries require reoperation for many problems like pseudoarthrosis or curve progression, infections, implant removal, many things. But in general, the picture is not that bad. 87% implant survival at 15 years is a good number. What about the progress of the curve? How fast the curve is going to get worse? That depends on the curve magnitude. More curve, more bad. Less curve, less bad. That's the generalization. Depends on the corpse angle. That's what we use to measure the extent of the curve. What is the remaining growth? If too much growth is remaining, it will become worse. Too much growth is not remaining, it will become less worse. And lower body weight, interestingly, makes the progress faster. So plump people do not have so much worsening. So the general dictum is small curves in more skeletally mature patients have a lower risk of progression compared to more severe curves in more immature or younger patients. What if you don't do anything? Obviously. So they have higher self-reported rate of arthritis, poorer perceptions of their overall health, their body image, and they have higher significant backache. So I think when the extent is too bad, it is preferable to correct it. Pulmonary function, those who get operated from the anterior approach have further worsening compared to posterior only. And even if you don't do anything, they do have gradual reduction in their pulmonary function. What is the future? Yes, everything about the gene expression. Try to find out what gene is abnormal. Try to manipulate it and see whether you can reverse the basic cause. That is the genetic abnormality. We'll see whether we can collaborate on that. Thank you. Thanks for your patient hearing. Do we take the doubts now or later? Now.
Participants, any question from your side?
Yes.
Yes, Mike.
Yeah. Yes. See, I said pediatric. Pediatric is a growing child only, ma'am. See, if you leave it, you either change the growth. So if it is growing like this, that means this is growing more compared to this. Either you push this up or you stop the growth of this. You understand? So you are playing around with the growth. So those two rods, which I showed on the concave side to stretch, and the screws that are put on the convex side to stop the growth. They are both growth modulation surgeries. But not everything can be corrected by that. When you feel that further correction or full correction cannot be gained on this, you do the typical surgeon's way. What is surgeon's way? Break it and get it where you want it to be.
Any other question?
Yes, sir, as you have told about the congenital one,
Yes.
where fused vertebra is present.
Yes.
So in that condition, if 4 or 5 vertebrae get fused,
Yes.
how you will correct with the plate?
See, if it is half fusion, the way in one of the pictures only one half was fused, the other half is also fused. Okay. If it is, the whole thing is fused, you correct the deformity at that level, they are not going to grow. They are fused means the growth plate which should have been there in between the vertebrae are not there. So if half is there, whatever is half is there, you remove it so that they no longer grow. Suppose they have grown by the time the child is seen, it is already curved. You correct the angulation and then you fix it. They will not grow anyway. So it is curved. You make a cut, you straighten it and you fix it.
You have to cut that part.
Yeah. So
One more thing about that neuromuscular
yes,
scoliosis.
yes.
So whether it will come under that congenital one or
No, it's a different variety. See, congenital means there is a defect in the bone because of which the bend curve is gradually progressing. Idiopathic means we have no cause. It is somewhere there. There is a cause. There is a weakness of the spine. The onus of maintaining a straight posture is on your muscles. If you remove all the muscles in a paralyzed person, the spine does not sit straight. So if the muscles become weak, they become bent. So you have to maintain the straight posture. You can do strengthening, but not always it works. So what you have to do, you have to go to the end of the curve. Suppose the weakness is here. You have to go till the normal segments. Most of the time in neuromuscular scoliosis, the fixation will be from here to here. He will tell more. So it will start from the bum and all the way till the neck. Stiff, like an Iron Man. Because the most of the reasons for this neuromuscular scoliosis will be muscular. They will be general problems. So it is not like only so much is affected. The whole muscles are affected. If you do so much, then this muscle will tilt. So you have to fix the whole thing. The neuromuscular scoliosis is top to bottom fixation.
thank you so much, sir.
So I'm happy to have one question from this side and one question from this side. So both sides are not sleeping.
Okay, so from this side.
How about in post-operative orthosis?
Post-operative orthosis, see, commonly it is not needed. When you do the fixation, depends on the pain tolerance. Pain, as you see, is subjective, number one. So if the patient can tolerate pain, usually braces are not needed. But if the pain is too much, you need brace. Then it depends on your fixation. Sometimes because they wouldn't have been mobilized for so long, their bones will not be strong. When you fix it, your fixation will be a bit touch and go. In that situation, you would like to fix it and support it till the fixation gains strength. Okay. So both for pain relief as far as for supporting your fixation.
Does it seem like, so is it okay if I compare the same amount of recurrence of curve gonna occur after removal of a brace, after weaning of a brace and after surgery? Is the
The-
percentage of
the
recurrence
brace-
is common?
The brace given after surgery is probably not to prevent curve progression. No. The curve will progress, yes, if your implant fails. If you have fixed it to the body, it comes out, plucks out of the body, it will fail. To prevent that, yes. But overall, the curve progressing despite a good fixation is unlikely. And if you're thinking you are giving a brace after surgery to prevent a curve progression, no. No.
And I just want to know, is that the part of the management after
No, it is
surgery?
only temporary for pain relief
Okay.
or till this fixation becomes strong. To
Okay.
prevent further progression, no. You have to do your job well.
Yes.
Excuse me, sir.
Yeah.
What is truncal shift?
Trunkal shift means, suppose my trunk is shifted like this in this part. My upper body will shift in this part. So you get the S. So my head is in line with the sacrum. Suppose I tilt like this, but the tilt is so much that my compensation is not complete. So my head is not in line with the spine. So you are always standing like this. So your body line of weight transmission is not central. You are loading more on one side, loading less on the other side. That needs to be brought to the center. Whenever you are doing, your line of weight transmission has to become central. So if the compensation curve cannot compensate fully for your primary curve, there's one primary curve and a compensatory curve. If the compensatory curve cannot compensate, then you become tilted. And that can also be there. They can be standing like this. That itself could be the problem. They will not say they have a spine issue. They stand awkwardly. Yeah.
Scoliosis could happen also, and we have seen due to unilateral amputation on one side. So
yeah.
we lost mechanical advantage. Somehow it's difficult to say exercises or.
Yeah.
So
See what happens, whenever there is a limb length difference, I gave only one line about it. The issue is my style, sorry, is I cannot deal with everything in few things in 20 minutes. When you try to put all the monkeys in one basket, it becomes diluted. So that's why first I said, I will be talking on idiopathic scoliosis. I just touched upon neuromuscular and congenital. Now coming to your question is about a compensatory scoliosis. You have a difference in leg length. To compensate for the difference in leg length, the pelvis is tilted down and the curve has develops. So your question, amputation is there. They're not putting the weight properly, or they're not doing this.
or even upper limb amputation.
Upper limb amputation causes scoliosis, is it?
Like the mechanical advantage and the axial load on the spine is different from side to side.
Uh-huh. If there is a primary cause which can be corrected, correct it. If you can equalize the limb lengths in the lower limb or in the upper limb, you can do something to sort out the primary issue, correct it. If the primary issue cannot be corrected, you correct the secondary problem, which is the scoliosis.
Thank you.
Yeah, deal it that way. Done? Thank you. It shows you are not sleeping. Thank you.
Sir, please. So thank you, sir. It's a very interesting and informative presentation. Would like to request Mr. Navid to come and give moment to Dr. Prashantina. Thank you, Mr. Navid. Mr. Navid, can you stay? So I like to request now Alvina ma'am, our executive director of Mobility India, to come and present the memento to Mr. Navid. Thank you, ma'am. Thank you, Mr. Navid. Our next speaker is Dr. Arjun Kumar. He is going to talk about the spinal deformity and management. So, Mr. Arjun, Dr. Arjun Kumar has completed his MBBS from Manipal University and postgraduate from Sanjay Gandhi Institute of Trauma and Orthopedics. At present, he is doing the spine fellowships from the Sanjay Gandhi Institute of Trauma and Orthopedics. His interest is in pain management and cervical blocks, deformity correction, historic approach to a spine problem. So please welcome Dr. Arjun Kumar.
Good morning, everyone. Okay, fine. So let me start my talk. So it's basically upon spinal deformity and its management in scoliosis. So again, scoliosis is derived from the Greek word. Greek scoliosis means crooked. So any lateral deviation seen on a radiograph greater than 10 degrees is called as scoliosis. Any curve less than 10 degrees is called as spinal asymmetry. Now, what is the etiology? As Sir told, 80% of it is unknown. We have seen that it develops between the ages of 8 and 15, which is predominantly in the growth spurt of the child. Now, female sex is highly prevalent, 7 times more. In this 80% of unknown cases, 3% of the curves lie between 10 to 20 degrees, and only 0.3% of the curves have the magnitude of greater than 30 degrees. Now, to have a better understanding of scoliosis, we basically divide on the clinical aspects into two things, whether it's a structural scoliosis or a non-structural scoliosis. Now, structural scoliosis is basically compensatory or a postural type of scoliosis. Non-structural scoliosis. Structurally is corpse angle greater than 25 degrees seen on side bending radiographs. Now, what is this non-structural scoliosis? A reversible lateral curvature of the spine that is positional or dynamic in nature. You have to make sure that there is no rotational abnormality in those spine. There is no structural abnormality in those spine. Now, how do you correct these? You correct this either by forward bending, side bending, changes of position in the pelvis, any particular contraction of one group of muscles, or by correcting the limb length discrepancies. Now, to see good examples of it, you can see on this particular image, in the first picture on the left-hand side, you can see that patient is having a thoracolumbar curve. And as soon as she bends forwards, you can see that the whole curve disappears. Now, in this figure B, you can see that the gluteal fold is lower down, as well as there is a thoracolumbar scoliosis. As soon as the patient is made to sit, because the limb length discrepancy is equalized, the scoliosis disappears. In the picture C, you can see that there is a sciatic scoliosis is basically whenever the nerve root gets irritated by the disc or any other canal stenosis compromise, the nerve root is affected, and there's a group of contracture of particular muscles, which gives rise to a scoliosis. So you need to understand. So based upon structural scoliosis, we further again divide idiopathic based upon the age, infantile, juvenile, and adolescents. Further classifications are neuromuscular, congenital, degenerative, traumatic. We also have neurofibromatosis, extraspinal disorders, infection of the bones like tuberculosis, which is prevalent in our country, and metabolic disorders like rickets, osteogenesis imperfecta, mesenchymal stem cell disorders like Marfan's or Ehlers-Danlos. Now, clinical examination, Sir has already detailed in descriptive details. How do we see exactly? We focus more on neurological abnormalities. And once the patient walks into our clinic, we have done a thorough clinical examination, and we now have a rough idea regarding what type of curve he has, what type of scoliosis he has, whether it's structural or non-structural. Then we get the radiographs. Why radiographs is important to us as a surgeon is basically we get to know and define what is the structural curve in this particular patient, what is a compensatory curve, What is the magnitude of the curve? How much is the flexibility of the curve? How do we classify this curve based on upon our linkage classification, and whether the shoulder balance is there, pelvic obliquity is maintained or not. Now, this is the X-rays how we take. So this is a standard AP X-ray. So we ask the patient to look straight, and we also make sure on the lateral view, this is the AP view. This is for the lateral view. You can see that, there is no ornaments or nothing. If the limb length discrepancy is more than 2 centimeters, only then we use blocks to make sure we get the adjusted height and to make sure there's no pelvic asymmetry in those patients. Now, this is the standard X-ray which we obtain in all our clinics. You can see that this is a 36-inch film. It covers from complete cervical spine to the complete sacrum in the coccyx also. The distance of which it's taken from is about 72 inches. Please make sure you remove all the ornaments and clothes of the patient so that we don't get artifacts on the X-ray. Now, this is how we do a supine side bending films. These are very important to us to determine whether the particular curve is structural or non-structural. Now, what is required for this is a clinician has to accompany the patient to the X-ray room. And we also need to make sure the patient is passively bent and it's supported by the sandbags to maintain the magnitude of the curve. Now, this is the example of the supine side bending curves. Now, after the particular radiographs, what do we see in these particular patients? One is the coronal balance. Now, coronal balance is dropped by two things. This is the plumb line, which we drop from the C7 vertical, and this is the centrosacral vertical line. And on the lateral view, again, we use the plumb line from C7, and where it drops on the sacrum, this gives us the sagittal balance of the patient. Now, ultimately, our goal in any surgery is to correct the coronal balance and the sagittal balance, make sure the patient has both equally so that he can go for a good proper gait. Now, these are few radiological nomenclatures. I do not know how useful it is for you, but I would just like to go through it for each one of you to help us how do we define curves. Now, end vertebrae are basically at the end of the curves. You can see these are the end vertebrae, and it's basically as no rotation if this particular information is enough. And apical vertebra. Now, the apex of the curve as a vertebra which is highly away from the centrosacral vertical line. So this is called as apical vertebra. We have something called as neutral vertebrae, and we also have something called as stable vertebrae. We also have something called as inflection vertebrae. Now, inflection vertebra is basically when the curve changes from it may be a structural curve, non-structural curve. And once you see the variation, that is the area where you see an inflection vertebra. Now, this is on standard radiograph. You can see that this is the centrosacral vertical line. This are the two end vertebrae. These are the apical vertebrae, and this is the stable vertebra. Now, need for MRI scan. Do we actually need to get MRI scan in all scoliosis patients? Answer is no. When do we need to do it? Whenever the patient is too young, probably CNS has not developed well, you are suspecting a pathology, intraspinal disorders, especially you have Arnold-Chiari malformations, you have intraspinal tumors, cord tethering. If you are suspecting all these, please do get an MRI done, because just fixing up or it will get worsened once you start fixating the structures. Now, curve progression. This is something which I think so should be the talk of the day. So how do we determine that this person is going to have the curves to be progressed or not progressed? Now, based upon it is, one is skeletal maturity. How much growth is left? Second is the magnitude of the curve. Now, how much growth is left? We determine by something called as riser's sign. What is this riser's sign? This basically iliac crest as an iliac apophysis. So they usually join with the amount of age. Now we divide it into riser 1 to riser 5. 1 is basically which we see around menarche age. 5 is when the fused. Now this is a pictorial representation. On the left hand side, you can see we have divided the iliac crest into 4 quadrants, and 25% of each is stage 1, stage 2, stage 3, and stage 4. And the right hand side, you can see it's completely fused. So it is the riser stage 5. Now, what are the other modalities? Yes, patients who are younger than age group of menarche. What else we do? We use Sanders age group. We can use the Y cartilage of the elbow, and we can use the phalanx also to determine the age. Now, why do we need riser sign? Yes, so if you can notice here, riser sign 0 to 1. Whenever the curve is 5 to 19 degrees, you can see the curve progression is 22. But in stages of 2, 3, and 4, it's just 1.6. it has dropped down significantly. Again, in curves of 20 to 29 degrees, it is 68%. In stages 0 and 1, drops down significantly to 23%. So this is very important to us to determine how the curve will progress. Now, how do we measure the magnitude of the curve? The magnitude of the curve is measured by Kopp's angle. How do we do it? Again, these are basically, you can draw these two lines and extend it if you're possible on your packs. You can directly get it. Or you can, these are the other mathematical way to draw perpendicular from the lines to get the Kopp's angle. Ultimately, the measurement is the same. Upper end plate, lower end vertebrae, draw the end plate. Now, rotation of the vertebra. How do you determine the vertebra is rotated or not rotated? Now, we do it by the basis of appearance of the pedicle, how we see on the radiographs. So we basically divide it into 4 quadrants. And this is how we see whether it can see it on the vertebra or not. Now, there are so many curve patterns which have been described since 1984. This was done by King and Moe. He basically divided the whole scoliosis into 5 types. There are a lot of demerits in it. We could not apply. Only thing he brought about was the concept of selective fusion. If you have a curve like this, you have a curve here, you have a curve here, you have a curve here. You don't need to fix all the curves. You just need to fix the center part of the curve so that you get a better alignment. Now, this is the currently used detailed Lenke description. If you can see, there are 6 types of curve pattern. There is a structural criteria based upon, again, 2 things, whether there is a kyphosis of the patient and side bending films if the Cobb angle is greater than 25. You have sagittal modifiers, you have lumbar modifiers. So based upon all this, we get approximately 44 different patterns of curves. And our treatment goes upon identifying these 44 patterns and based upon which we give further treatment. Now, sorry. Yeah, this is a treatment algorithm which we use technically. And to simplify this, let's make it into 3 particular ease of ways. One is observation group. Observation group, what do we do? Curves less than 20 degrees and in patients less than 40 degrees in a mature patient, non-progressive curves. We keep them under observation. Bracing group, progressive curves, curves between 20 to 40 degrees and a cooperative patients. We always need to make sure the patient's mental health is sound so that he is cooperative with us. Next is the surgical group. Surgical group is for curves greater than 45 degrees. We get a lot of patients who have this cosmetic deformity, who are not able to go outside because of this cosmetic deformity. They come primarily to us for the surgery for that reason. We have whenever the brace is failuring, or we have a lot of thoracic kyphosis or lumbar lordosis, which is exaggerated, and pain. These are the main reasons why we do surgeries on these patients. Now, this is the typical patient in which we do observation. How do we do the observation? We just get the AP and the lateral views for these patients. We document their Kopp's angle and the skeletal maturity. Every 6 months once we do it. We don't ask the patient to come every time. If you can see this X-ray, this was taken in June 2018 and November 2018. You can see the curve has progressed. Now, bracing. There are a lot of eminent faculties here. I think so senior faculties who will talk to you about bracing much better than me. So what do we see as a surgeon's perspective is simple. Every 3 months once, we follow up this patient with AP and lateral views and documentation of Kopp's angle and skeletal maturity. Whenever we apply brace, the good prognostic indicator is the correction of the Kopp's angle by 50%. So this is the patient. You can see the magnitude of the curve. This is after we have put the particular brace. You can see the straightening of the spine. So we can say that this patient will do well with the braces. And this is not from our center. This is from somewhere else. You can see this is from the pre-treatment. The Kopp's angle was 33 in treatment. And after 2 years of follow-up, you can see that this has come down to only 6 degrees of the curve. Now, indications for surgery. Again, I've already told, main thing is patient's cosmesis and pain. These are the 2 things. And curve greater than 45 degrees and affecting the cardiopulmonary reserves. These are the things which we actually look about it. Now, goals. Simple, maintain coronal balance, sagittal balance, improve the cardiopulmonary function, minimize the pain, minimize or prevent new deformities and prevent the existing deformity. Now, again, I told you there's a Lenke classification based upon which we decide to fuse the levels. This is a comprehensive classification. I've just put the slides for you guys to know that based upon this, our treatment goes about. Now, Trobis, basically, he gave us the criteria for the shoulder balancing. So many patients of us are there who have right shoulder elevated, who have left shoulder depressed. So based upon that, till what level we instrument based upon that is this. So Lenke 1, 3, and 6, basically for the shoulders. T2 is whenever the D2 or the T2 vertebra, D3 when the shoulders are level, and D4 when the preoperative right shoulder is elevated. Whereas in 2 and 4 type of curves, we only instrument it till D2 because we need, and these are thoracolumbar and highly progressive curves. And type 5, we can just look at the upper end vertebrae. And what is the surgical goal? Or who is the best surgery, or how do we assess we have done a good surgery? So first is the fusion mass. What are we doing? We are basically fusing up all the spines. There is no mobility in each spine or in the disc spaces. So it has to be in the stable zone. We should make sure the shoulder and the pelvis is level. And we should also make sure that whenever the extension is beyond L2 for fusion mass, there is always the risk of adjacent segment disorders, risk of increasing spondylolisthesis or a break. Now, this is just an example. How do we go about it? So this is the particular X-ray in AP view. You can see proximal thoracic curve, middle thoracic curve, and the lower lumbar curve. So you can see the proximal thoracic curve is only just 15 degrees, and the mid thoracic curve is about 40 degrees. Based upon the Lenkes classification, we go to A1 type, and you can see that T2 to L2 kyphosis is around 20 degrees. Now, after correction, we bring in the concept of selective fusion. You can see we have just fused from D5 vertebra to L1. We can also see that this complete correction of this curve also and this curve also. You can see the 15 degrees of proximal thoracic curve is corrected. You can also see the lower lumbar is also corrected just because of the concept of selective fusion. Now, surgical options. How do we do it? What do we do it? We have posterior correction and instrumentation, which is the workhorse. Most of us do posteriorly. Few of us have preferences of anterior correction and instrumentation, like pioneers like Sajan Hegde sir. And we have, combined approaches also we do once in a while, whenever there's a tough cases based upon the case. Now, what are the fusion techniques? Now, there are a lot of fusion techniques. We basically depend again on the Lenke classification for these fusion techniques. There is in situ bending. Basically, we apply the pedicle screws and then we bend inside the operation theater or the rod to achieve the correction. There's a cantilever principle. This is, I think so, engineering people will be knowing this much better than us. What we use is this particular method. So this is basically rod derotation method. So we take a rod, we pre-bend it before we apply it to the pedicle screws, and then we rotate the whole vertebra so that we achieve the correction. And this is the other posterior middle translation method. This other 3-rod technique, it's called a Cottrell and Dubois technique, which we use it for very resistant or very highly progressive cases. Now, what are the instruments we use? Mostly is pedicle screw or hybrid construction these days. Pedicle hooks have come, laminar wires have come, although laminar wires we are not using much these days. Now, okay, let me just go through this image. I think so the images are more, speaks for itself. So this is the particular patient. We can see the curve here. We have already inserted the pedicle screw, about 90% of the density on the side of the curvature. And then you can see that once we have achieved it here, you can see that slowly will be derotating. And once we derotate the whole thing, you can see on the picture 7, it's completely straightened out. Although our job is not done here. So on the second rod, what we use is the right rod, which also corrects the deformity of the rib hump. And we also need to make sure we have this compression and distraction. If you can see in the previous images, all the innies and the pedicle screw are equidistant. Now you can see few are closer, few are farther apart, because we have achieved some compression and distraction at particular stage of the curve to get the optimized results. Now, this is the intraoperative picture. This is how we position a patient. You can see the right rib hump. And this is after our exposure. And this is after our correction. And anterior release is not very common. It's kind of very risky procedure. The way we go about is from the D10 spinous process. We go along the lateral aspect of the curve. We completely open it up. Then we have to go through the diaphragm. Then we have to go through the retroperitoneal structures. Then we reach to the lateral spine of the patient. Now, this is the intraoperative picture. How do we use it? These are pre-contoured rods, which we have already changed to get the correction. And this is a particular cage. So to bring about, whenever there's a space between the two vertebrae, we need to bring out fusion. Either we can go through a bone graft, which is again painful for the patient. Rather, we go for a cage or a PEEK cage. And this is the correction what we have achieved. And how do we correct kyphotic deformities? Now, there are various classifications. Now, there's 6 grades of osteotomies. Basically, do we just remove the facet? We will remove the whole facet with the pedicle entry, complete pedicles out, or the complete vertebrae are out. Now, schematic representation of the same thing. First is a Smith-Peterson approach. And this is what we commonly use. This is something which we commonly use to achieve. This is called as pedicle subtraction osteotomy. So whenever we have the tendency to go through the pedicles, we carve out the whole pedicle. We make sure that this particular bone structure is reserved out. Then we compress using the rods, connecting rods, and then we're able to achieve the correction. In this is a place where this is called as vertebral resection osteotomy. We basically have removed this particular vertebra and we have joined with the two vertebrae. What you can see is something called as expandable cages we use, or we use the mesh cages with the bone graft. Now, newer growth rod techniques, which is basically for the patients who are very young. We don't want to compromise the height of the patient, and we want to make sure the height is retained. So this is a very newer technique, but the problem with this is every 3 months to 6 months, we need to revisit to the surgery and we need to alignment and change the rod length. So this is one of our cases. We usually don't do such cases in our center because of economic problems in government setups. And this is the way we do it. We just fuse the upper ends and lower ends. And this we keep up to changing intraoperatively every 6 months once or 3 months once. Now, how do we take care of the pain of the patient post-operatively? So one is intravenous antibiotics are going on, and we always keep a epidural pain catheter for patients because it's a long procedure. You can see from up to down, we have already exposed the spine. It's a lot of blood loss is there, a lot of morbidity is there. Now, what do we expect? How do we treat the patient? The day one patient is in the ICU. We need to make sure there's no other problems, especially with the cardiopulmonary reserves. Day one, we'll make sure the patient is doing in-bed mobilization. Day 5, we make him sit up. 1 week, we make him stand up. Now, 3 to 6 months of age, the scoliosis correction, we avoid the patient to do any activities because our patients do not listen to us mostly, and they do as they feel like. So most of our patients are, we put them on a brace. Usually we put them on a brace for the first 3 months because we don't want them to inhibit fusion. Fusion is a slow process. It's a process of 1 year. It's not going to happen over 1 day. No matter how my correction is good enough, if the patient has not given chance for the whole thing to fuse, my surgery is going to be a waste of time. Next is how do we post-operatively follow up these patients? So once the patient starts walking independently, that's the day we decide the patient to be discharged from our center. And so we take follow-up X-rays basically on 1, 3, 6 months, 12 months, and 24 months. Basically up till 2 years, we follow up the case. Now, what are the complications after surgery? First is neurological injury. Please bear in mind, most of our patients do realize there is 1% chance of paraplegia, which is significant risk. Although the risk has been gone down now with the neuromonitoring cases, which is coming, we have a low anesthesia, we have every other help, but it's not 100% proof. But we still have a lot of risk of dural tears or neurological injuries, nerve root injuries, which can compromise the activity of the patient. Next is the infection. Infection again depends upon the type of setup. It's usually around less than 1%, most common organism Staph aureus. Paralyticus ileus, it's a common complication of any GA surgery. Atelectasis is, yes, when you're accompanying or operating on spine with thoracolumbar scoliosis in the thorax, yeah, we may inevitably injure the pleura, or we may even create a subcutaneous emphysema. There might be cases of pneumothorax. If there is a risk of pneumothorax in the postoperative X-ray where we can see air under diaphragm or something like that, then we put in an ICD tube. So dural tears are quite common. We just stitch up the dura with 80 or 70 proline, and urinary complications are also quite common. Now, late complications, 2 years follow-up, 2 years X-ray is done to prevent these. Now, what are these? Pseudoarthrosis. Basically, fusion is not happening. Whenever there's not fused, bones are wide apart, there is pain of the patient. And this is something which we need to worry about. This is called as flat back syndrome. Basically, after the surgery, we as a surgeon or as a brace failure or whatever it is, we tend to make sure the lumbar lordosis is not corrected. So, or the normal curvature of the spine has not been achieved after the surgery. So you can see on the left side with the newer growth rod techniques, this is one of the problems. And after this, the patient will be having easy fatigability or pain during walking. And this is the crankshaft phenomenon. Basically, we fuse the spine posteriorly. The anterior vertebrae are still growing. This gives us the rotational deformities you can see in this. And implant failure, basically, whenever there's a cutout of the rods, hooks, we have this. Now, these are the cases which we did in our center. This is a 13-year-old boy with a scoliotic deformity. This is the erect spine, supine side bending films. This is the post-surgical images. And this is the post-operative X-ray. You can see we have just done the selective fusion. We are not completely fused the whole thing. Again, this is a 19-year-old with an ankylosing spondylitis case. This is a preoperative CT. This is the patient with a downgauging sign. Post-operatively, this is the correction. We have achieved the lumbar and coronal and sag balance in this particular patient. Again, this is a 18-year-old female, again with thoracolumbar scoliosis. This is the preoperative images. Again, selective fusion done. This was done a long level of fusion. This was the correction which we were able to achieve in our center. And these are basically few MCQs which madam asked me to put up. And basically, this is only for telling that, when do we do spinal manipulations or anything else. Apart from this, we don't need to discuss all this. I think so. I'm done with my talk. Thank you so much. Anyone have any doubts, please?
You can take maximum 2 questions.
Yes, ma'am. Thank you.
Only one question. Since you talked about linkage classification as that stays as a blueprint for surgery management. So linkage classification talks about lumbar modifier and sagittal modifier.
Yes,
So
ma'am.
since scoliosis is a 3D deformity, it also has rotation.
True, ma'am.
So is there any rotational modifier or something, any reference do you have for that?
Ma'am, basically to read linkage classification, you need a month. Okay, so there are 44 types. There are almost 64 subtypes. So our treatment is based upon the chart which I discussed. So we need, scoliosis correction is not a big deal, to be honest. It's basically good pre-op work. If you've done good pre-op work, intraoperatively, it's going to be damn easier. But then if your pre-op X-rays are not adequate, you're not taking correct side bending films, you do not know where exactly is the rib pump, you're not planned for when to fuse the upper vertebra, which is the side of convexity. These are the things which matter intraoperatively. But I think so any surgical success is basically based upon the preoperative work, madam. And linkage classification is just a guide. Although recently from 2008, they have also told a lot of bias or falsity of the linkage classification, which we are working upon it.
Sure, thank you.
Yes. One more doubt. In case of hemivertebra or which vertebra, so surgical management, whether you will fuse the fusion will be on
Hemivertebra, sir. There are many types of hemivertebra. Look for one thing, whether there is disc above, disc below. If you have disc above, disc below, it means to say that there's a potential for the growth of the particular curve. If it has fused already, if there's a bar, there's no risk or there's no progression which is going to happen. If you have a disc above, you have a disc below and it's completely wedged out and it's progressing, then remove the complete excise of the vertebra, fuse it, compress on this side, expand on this side, achieve the correction. Simple.
okay. That fusion will be on the particular functional spinal unit, or it will be a
It's not as broad as this. No, it's going to be just 2 segments above, 2 segments below. And that's basically for us to make sure the pedicle screws which we have put in is adequate enough to bear the load and the stresses. If we feel the patient is too obese, too thick, we might have to extend 1 level above and 1 level below. Thank you.
Thank you, sir. It's a very interesting, informative presentation. And I'd like to request Mr. Navid to present the moment to respected speaker, Dr. Arjun Kumar, as a token of gratitude. Thank you, sir. So before break, we have 2 more presentation. So our next speaker is Dr. Mayura Kundra. She is a clinical physiotherapist. She will be talking about the unlocking the potential of conservative scoliosis treatment, principle and practice. She is having more than 10-year experience in this field. She is an internationally trained physiotherapist specialized in spine deformity, scoliosis and kyphosis for non-operative, pre and post-operative patients of all ages. She is certified growth therapist from Germany. She has completed her master course on principle and practice of scoliosis conservative treatment from the Italian Scientific Spine Institute, Italy. She accredited scientific exercise approach to scoliosis therapist for scoliosis and other spine deformity. So please everyone welcome Dr. Mayura Kundra.
Good morning, one and all. Yeah, so what is the use of bracing? Why do you want to torture your child by wearing a brace? Or physiotherapy is not going to help. This is what I used to hear, say 7-8 years back when. So this is, you're able to hear? Yeah, so this is what I used to get from either the doctors or many of my patients who had approached the surgeons and whose curve was say about 30 degrees and still they were told, why do you want to? But without trying, we wouldn't know how it would help. So this is how slowly we started working on to it. So as we've already discussed, so the scoliosis is it's diagnosed as scoliosis when the curve is about 10 degrees and more than 10 degrees, and there is a rotation factor. So on forward bending, you have a angle of trunk rotation of more than 5 degrees. So as we already discussed, so the changes are in 3 planes here. So in the transverse plane, you have the rotation. In the sagittal plane, you see that, you can see that as Dr. Prashant said, it is not kyphoscoliosis. The kyphosis is rather reduced, and also the lordosis. So there's a rather flat back in people with scoliosis. So you can see that I've drawn the blocks here. So it's to describe how the changes happen in the body. Like if we divide the body into blocks, so you see that the rotation, the right shoulder is forward, the right ribs are prominent, and here you can see that the lumbar prominence and the pelvic obliquity. So the natural history is well described by the vicious bone circle of Ian-Stokes. So it starts with a deviation in the spinal curvature, leading to asymmetrical loading and leading to asymmetrical, hence leading to asymmetrical growth and wedging of the vertebra and disc wedging, finally, leading to structural scoliosis. So how we work on this? So that was the vicious circle. So we work by correcting the spinal curvature. So reversing the asymmetrical loading, hence reversing the asymmetrical growth, and working towards reversing the vertebral wedging. So it is likely that most structural spinal deformities start as functional curvatures and only become fixed over time. So it is necessary that we start working on it earlier. The earlier, the better. So as you see here, so when the plant is young, you can correct, and once it is grown into a bigger curve, it is much harder to correct with the earlier, with the conservative method. So when is it too late? So when the Cobb angle has crossed 50 degrees, at the end of growth phase, that is at RISA-5 or say 18-year-old, about approximately at that time. So if the at the end of growth, the curve has crossed 50 degrees, then there is a chance of progression through the adulthood. So the goal of our conservative method is to maintain, is to try and maintain. It's not as easy, but it is to try and maintain below 30 degrees. So there is no further progression in adulthood. So yeah, this is with regard to where our, when we're speaking about the conservative treatment potential. So this is where our first role starts as conservative practitioners. So to detect early and correct. So how do we go about it? By promoting either awareness, maybe now it is much easier through social media, or conducting screening programs, or working towards getting the, what do you say, school screening programs as a must at schools. Why do we need to do that? So at school, so what happens is when the parent detects that the child has scoliosis, it is already say about 40, 45 degrees, 30 degrees. So somewhere much ahead of the, towards the boundary of surgery. So why? It's normally around 8 to 10 years of age, or from 10 onwards, around the menarche age that it starts. And at 8 to 10-year-old, your child is independent, bathing on its own, dressing on its own. You don't even see the child. They are independent. So to observe a mild curve, you have to see, you have to take off the clothes and see. It's not visible through the clothes. So only when it is 30, 40 degrees, it is visible as a rib hump or a waist, you know, the movement of the waist is seen. So it is mandatory that we catch them young to get good results from conservative method. So coming to, so how do we catch them young? Either by the body asymmetry. It is easy, it is not at all difficult. So you catch them with the body asymmetry and also the forward bending test. This is the thing that you can do at the screening programs. But clinically, how do we assess? Clinically, I follow the method from the ISICO. So that is called the TRACE for learning the aesthetics. So this is trunk assist aesthetic clinical evaluation. So it also helps you to assess without an X-ray with your therapy or with your bracing, how much it has helped. So probably you have a review every 3 months, and the parents are also anxious whether we should get an X-ray. Every time they want to do an X-ray and see, but X-rays, as you know, are not very good. So once in 6 months or once in 12 months is what we want to refer them for X-ray at a maximum. But this clinical evaluation can help you in guiding whether it is progressing or whether it is contained. So TRACE here has a, what do you say, the giving points. So if you check the shoulder levels here, you have the first picture, you can see that it is, so here you give 3 point scoring, 0, 1, and 2. So 1 is slightly deviated and 2 is more. And also there are 4 points that you see in TRACE. So the shoulder, the scapula elevation. So you see here, this is 1 here, you can see the scapula, and here you can see the scapula is further gone in into the concavity. So that is 1 and 2, and a hemithorax. So if we divide the thorax into 2 parts, you can see that here it's almost equal half, but you can see that if you draw a line here, it is more on this side rather than here. So this is how we score, and also the waist asymmetry. So here there is mild, and that is 1, 2, 3, and 4, where you, in the 4, you see that's a straight on one side, and the curve is, the hip is prominent on the other side. So that was for your body asymmetry, and you check the central sacral line. Here again, the truncal shift that we were talking. So the more the truncal shift, it's more towards surgery, if I believe. So this also gives us a regular check of this also gives us a feedback of where we are standing, or in fact, after bracing, you can check whether it is aligned or not. And this is to check the rotation. Here we give negative values and positive values. And also this is an indicator whether there is a slight change in rotation post your rehab or post your bracing. Again, the sagittal profile assessment is also taken. So you will see that the kyphosis is much reduced, probably in the bracing. We can try to involve a lot of whether we can include kyphosing into the bracing. So sagittal profile is more important, and it has been there are papers saying that when the pain is more related to the sagittal profile rather than the other planes. So coming to the X-ray here, as Dr. Prashant and Dr. Arjun described, we again see for the cob angle and the alignment or the truncal shift or pelvic obliquity. You can see that there is rotation. You can also see the ribs on the convex side widen and the ribs on the concave side. I'll come to this when we come to the therapy. This is closer, and RISR again we are using for taking calls about when to do the bracing, when to start, when to stop. So here, as described, so RISR 0 is when it is highly progressive, and RISR 5 is an indicator to kind of stop the therapy or bracing. So how do you distinguish between RISR 0 and RISR 5? RISR 0 is when there is no ossification. Here, it is fully ossified. So you can see on this half, it shows the earlier, and this half, it shows later. So to distinguish between RISR 0 and RISR 5, you can see here the ossification on the femur head or the open triradiate cartilage. It shows that it is still RISR 0. And how do we go about the conservative method? So all the professionals who treat scoliosis use their own specific tools. Like for physiotherapists, we use the exercises, and orthotists use the bracing, and the surgeons do the surgery. So PAS or SOSORT is the conservative method. They have developed something called practical approach scheme. So to make it easy for us to how to go about the therapy. So initial stage, it is observation, then exercises, then elastic braces like the spinal cord, then plastic braces, hard plastic braces, casting or surgery. So the practical approach scheme is given by SOSORT to make it easy for us. So you can see that so here it is described, you can see the Cobb degrees. So the minimum strength of treatment and the maximum strength of treatment that can be given for each case. So it can't be fixed because sometimes the patient is compliant, sometimes they're not. So you have a range of treatment so that you don't overtreat or undertreat the child. So for example, for a child with the RISR 2 and 16 to 20 degrees, you can keep either on observation or part-time rigid bracing. So there is a range of, so if you take a RISR 5 and somebody with the 41 degrees at RISR 5, you can either keep on observation. So that doesn't mean observation or full-time observation, physiotherapy, bracing, full-time bracing. So all of that comes within this. So same for the adults and the elderly. Physiotherapy, scoliosis. So scoliosis specific exercises. Again, the SOSORT has approved a few schools as of yet, based on the evidence. So the Lyon method from France, Schroth method from Germany, again, modified Schroth from Spain, and SAYS, side shift, Dobermet from Poland, and Fitz. So these are, as of now, the evidence-based exercises. So the goal of the physiotherapy, scoliosis specific exercise, not the goal, or to fall into the category. So they should be curve pattern specific, involve a 3D autocorrection of the curve, and working towards stabilizing the corrected posture, and involve and include the corrections in your activities of daily living. So these are some factors. So how we work on? We want to work by breaking the cycle, right? The vicious cycle. So in the first image here, you can see how the gravity affects us. So the gravity affects, and the concavity goes on. The gravity is affecting us throughout the day. So the concavity is, so the concavity is further. So the deformity is progressing. Also here you can see that the ribs are, as I told you earlier, the ribs on the convex side is wider and the concave side is narrower. So we do here, okay, in the first thing I forgot to tell you. So to work against this, we use the elongation technique. So in the bracing also you give elongation. In the exercises also we use elongation methods to teach them how to hold. And here, as we say, the breath or the air goes wherever it is easier. So it goes more into the space that is further open. So further going towards worsening of the deformity. So in therapy, we work with breathing into the concavities. So to keep it open wide, or even in the bracing, you are keeping the concavities open with the braces. So here you can see that with the rotation, the body of the vertebra move towards the convexity, and the spinous process towards the concave side. So further pushing the ribs on the convexity backward. So the ribs on the convexity backward, causing a rib hump. And the ribs on the concave side are forward, moved forward or anteriorly. So the asymmetries that you see on the body in the front and the back. So it's described well this way. So this I would like to add in the bracing method because in the therapy, we work towards bringing this side, that is the convex side, ribs that have moved outwards and backward. So we work towards bringing them forward and toward the midline of the body. So same, I think, with the bracing you are doing at the apical rib, pushing it forward and towards the midline of the body. And what we do with the rib cage on the concave side is they have flattened. If you see posteriorly, they are flattened and they are more prominent in the front. So we teach the kids to teach the people to bring the left rib, or sorry, the concave, the concave side ribs sideways and backwards. So, so if the vertebral body is here, my thumb, and this is your rib cage. So this is come back and this is come forward. So the right rib, or right, why I'm saying right is it's more common, thoracic. So right, the So the curve, you see the deviations, the blocks have changed. So if it is a shoulder block, thoracic block, lumbar block, so there's a shift. So it's a 3-dimensional change. So in Shroth, we work by bringing the body to the best possible correction using props in these ways, in different ways. So using props to push the prominences back, to guide them, to bring the rib cage forward, and in the best possible corrected position, they are doing their breathing. And you can see here again, in different postures, they are trained to hold their, in different positions, they are taught to hold their posture. So they are trained in almost in sitting, in kneeling, in standing, in walking, in several ways to hold their posture through the, yeah. So this is the corrective breathing that we do. So you see here in the concavity, how she has done breathing and opened up the ribs here. So also exercises are taught in brace. One is to relieve relief, or more what I say is exercises in brace. So what I tell the children is the brace is not to sit into the brace. So the brace is to guide you towards your correction. So this is, we teach them how to move away from the padding, or to bring their, from their rib cage to the place. So this is how we train in brace as well. And regarding posture corrections in, or applying it in your activities of daily living. CS is a method from Italy, and here it doesn't use a lot of props like we did in Shroth, but the patient tries to manage the best possible correction through rotation, through shifting, and many exercises are given along with this, say hundreds or a different variety of exercises are given, maintaining this posture, so as to learn how to hold the posture. So Dobomed is a method from Poland. Here we put the child in different closed kinematic positions. So the what do you say, the shoulders and pelvis are fixed here and focused on breathing. So you can see here in the first image how the concavity, the convexity, here you see the rib hump, and the concavity is flattened. So there's breathing that he's doing, and you can see in the middle of the his gesture, both the ribs are at the same level. Now he's trying to exhale from the convexity, so almost reversing the rib humps. So it doesn't reverse, but actually opens up the rib. So these are the different positions based on different types of curves that we use for the same method. Side shift again is a method from UK, and they do not believe in very tough exercises like Shroth, or so they give a simple couple of exercises through the day, like to do repeat maybe 30 times a day. So it is based on the fact that when the curves are flexible, a lateral movement can correct the curve. So a lateral movement or the truncal shift can, or the shifting can correct the curve. So in a thoracolumbar or a lumbar curve, you can see that the pelvis is raised here, the opposite pelvis. If the lumbar is towards the left, the right pelvis is always raised, mostly raised. So here they're doing something called a hitch to open up this curve. So this is done 10 seconds a day for 10 seconds at once for maybe 30 repetitions in a day. And for a person with a double curve, so a hitch, again a hitch, and a shift in the upper. So, okay, these are some of the cases at my center. And here also you can learn the trace. So you can see the shoulder level is 1 or 2 here. And the shoulder, the scapula is inside and it is better over here. The waistline is better. So this is an adult, actually maybe 20-year-old. So he's past his progressive age. but only with the exercise in 2 months, you can see the truncal alignment, the coronal alignment. And this is again in an adult. Okay, this is a post-surgical case, and you can still see some residual changes here, but post exercises, this is what. So this is after bracing, after 2 years of bracing and exercise. There is some change. If not, the rotation has not changed, but there is some change towards. This is in a year, the lumbar curvature with rotation. Here is the X-ray of that child. So you can see the rotation has also changed, and it's quite aligned. With the high thoracic and two curves over here. Of course, for a cervical curvature, you need a Milwaukee, which is very hard to wear. So here we were able to get at least a correction in the lower thoracic. So, thank you. Yeah.
Questions? Any questions?
Any questions?
We can take up any 2 questions.
That was a nice presentation, ma'am. Thank you. And my question is these exercises modules that you have said is only for idiopathic, or it works on degenerative scoliosis and the
For
other types of scoliosis as well?
For adults, yes. For degenerative as well, where you can't do surgery or they are osteoporotic, maybe the surgery can't be done, and it is hard at that age. So it does help in adults as well.
Okay. So we do have complications in any of the management, like in surgery or in bracing. So with PT, with therapy, is there any complications or something, or any demerits of therapy?
Not necessarily. So, but you cannot assure that the curve can be corrected, because it is again the nature, and we can only try to maintain it. So the first goal, as conservative as Dr. Prashant said, first goal is to maintain, to try to maintain the curve. Whatever extra correction we get is bonus. So it is very hard to get the correction. It's not easy. It's very consistent. They have to be consistent with the bracing and the exercises. Consistency is the only key. So as we spoke, so it is equally on the patient's side for us to get result, how they perform. So there is no, negative aspects as such, but so you can't promise that it will correct.
Right, ma'am. Yeah. Thank you so much.
Yeah. That's it. That's it.
Thank you, Dr. Mayura Kudwa, for wonderful presentation. Now I would like to request Mr. Navid to present the memento as a token of appreciation to Dr. Mayura Kudwa. To Dr. Mayura Kudwa. Thank you.
So I'd just like to add something. So as I said earlier, there weren't many references, but from past few years, even the doctors or the spine surgeons, everybody's seeing some changes and are now working towards including conservative as much as possible. And I thank and I'm proud of Mobility India. I think you're the first one who have tried to bring a multidisciplinary team approach into this, and I'm proud of you. Also, I do get a lot of cases from all across the country for the therapy. So like from different, from Assam, from Chandigarh, from so many places. So I'm not actually proud of it, but I feel that at least half of you or 1/4 of you work towards this. And we have somebody to work on it in every town or city. Yeah.
Thank you, Dr. Mehra. So before break, we have one more presentation, and our next speaker is available online. So our next speaker is Mr. Arlis. He is the head of the piano department, University Trauma Hospital, Tirana, Albania. He is having more than 15-year experience in this field of prosthetic and orthotics. He will be talking about the evidence based on spinal orthotic management. Head of the piano department, and he is available online. He is not able to present physically with us. More than 15-year okay, so in this field of yes, he is available. Yeah. So please, everyone, welcome Mr. Arlis. Management. Head of the piano department, and he is available online. He is not able to present physically with us. Okay, so yes, he is available. Yeah. So
Yeah.
Mr. Arlis, management of the piano department, and he is available online. He is not able to present physically with us. Okay, so yes, he is available.
Yeah.
Mr. Arlis, management.
Good morning, everyone. Okay. Good morning, everyone. Can you hear me?
Yes, sir.
Hello?
Can hear you.
Yeah. Okay. So we can carry on then. Good morning, everyone. First of all, thank you for the invitation of doing a presentation about the evidence based on spinal orthotic management. I have this experience since I finished my studies in Mobility India since 2009, and it's a field of the P&O profession that it's endless learning process. So let's start with the first slide. The evidence of based on spinal orthotic management has been presented in 2013 from Stuart L. Weinstein. In this let's say research paper that came out with the final result of summary of conclusions that bracing in adolescent idiopathic scoliosis treatments significantly decreased the progression of high-risk curves to the threshold for surgery. A significant positive association between hours of brace and rate of success exists. And as the average hours per day increased, so did the success rate.
Just to interrupt in between, can you share your screen from there? Because, we cannot see your...
You are not looking at it.
No, it's too early for you.
No. The thing is that I thought that you are, I already gave the share screen. Can you, what about now?
Yes.
Can you see?
We cannot see the presentation fully.
Okay. Okay, just a second. I think you have the presentation. Can we do it like?
We will share from this side.
Okay, so I just continue with telling next slide, please.
Yeah.
So can you open? Hello?
Just a few minutes. One minute.
Okay, sorry. Yeah, that's good. Right. Audio, it's okay. Can you hear me?
Yes, sir.
Hello?
Yes, yes, sir. Yes.
Okay, so let's continue.
We will keep on
So,
right. So we will
so,
follow.
so yeah, for the next slide, I will tell next.
You can,
Okay, so
yeah,
we are on the first.
we are in the title slide.
Okay, okay. So as I told, have you? I think you heard me before. We can go to the next slide, please. Next. Yeah. Okay. So, randomized controlled clinical trials. These are the standards for ascertaining the efficacy and safety for treatment. In 2013, Dr. Stuart Weinstein, in a presentation about the BRACE, which is standing for Bracing in Adolescent Idiopathic Scoliosis Trial, he published the results online in the New England Journal of Medicine. So he reported that bracing of adolescents with moderate scoliosis was effective treatment in the reduction of the numbers of patients who advanced to the need for surgery. In addition, a dose response was found between the number of hours of brace and the success of rate of bracing. In this uh, research, a lot of clinical trials, let's say so, several medical centers work together to perform the highest level of medical study. So it was a study made for children and adolescents with curves between 20 to 40 degrees. There were about 242 patients participated in the study. Patients in the bracing group was assigned to wear a brace 18 hours per day. A special monitor was embedded in the brace to keep track of how long it was used per day, and patients in the observation group received no additional treatment. The endpoint of the study was treatment failure, defined as progression of the scoliosis to more than 50 degrees of treatment success, when skeletal maturity was reached within progression to 50 degrees. Next slide, please. Yes. So in our daily practice, the results of bracing depends on doctor team, which involves the surgical doctor, the orthopedic doctor, or the physical therapist, including also the orthoprosthetist. The patient, which is, let's say, so responsible for flexibility, response, and compliance, and doing the exercises given from the physical therapist, and the brace also, which is very, very important to have the three parts of it, the concept of it, the proper design, and the standard. Current concepts are inspired mainly more and more braces are inspired by Dr. Jacques Genot, which is called the Jacques Genot type brace, a French doctor, which in 1980s he designed a rigid plastic brace. And after that, there have been so many sub-designs of the original one. And the one which I like to work and is the 3D Rigo Chenot brace with the outdoors from Manuel Rico, Dr. Manuel Rico from Spain, and Dr. Mina Jelacic from Serbia. So the brace is for this type, it's a custom monovalve, ventral open, and rigid thermoplastic brace. And the mechanism of correction is the 3D torsion of it functional. Next slide. So for making the 3D, three-dimensional regressional brace is necessary that the torsional forces to achieve the desirable 3D correction can be produced with a static brace by combining three mechanisms, which are the three-point system in frontal plane, a pair of force for regional and local derivation, and the correct balance and physiological alignment in the sagittal plane. It has been previously with the handmade original technique, which we already know with the plaster of Paris bandages and with plaster modifying the mold, plaster mold. And now there are other techniques or technologies which are with the CAD/CAM, with the polyurethane form block, which is carved after doing the 3D scanning of the body and after doing the designing of it in the CAD software. Next slide, please. Yeah. So let's start with the first, let's say so, plan of working on a brace, which is the 3-point systems, and it's used mainly in the frontal plane. So the 3-point system is the application of a single 3-point system which serves to correct single spinal curvature in the frontal plane. And the efficiency of the 3-point system depends on the level and distance between the 3 pads designed to create these effects. As you can see in the picture, there are a combination of 3-point systems in it, which we can have like A. We start with a correction point from the cervical part or the high thoracic. We go to the mid thoracic and we go to the lumbar. And after that, there's the B line, which gives us the second 3-point system correction, which is in combination with the lumbar correction point of the first 3-point system and also with the middle correction of the thoracolumbar correction from the right side, if we say so, and the final correction line, which is below the iliac crest on the right side. So beside that, if we can say we can have 2 3-point systems working together, and also there are also 3 3-point systems which they can correlate with each other if we have, let's say so, 3 structural curves in the scoliosis curves in the spine. So next slide, please. The second system that we work on for doing the correction is the pair of force for regional and local rotation. The pair of force system consists of 2 contrary force in different directions applied on a wide section of the trunk at the same level in order to derotate the section. Example is the regional derotation. The pair of force system has to apply the highest force at the apical level where the vertebra is the more rotated in the local derotation. As you can see in the first in the picture at the A picture, you can see that the blue line is the body, the trunk, with the derotation of the vertebrae and taking also with them the ribs. So the application of forces, you can see that middle sagittal line arrow shows that it's the anterior part of it's the ventral part, and the behind that the posterior part is the dorsal part of the trunk. You see the arrows that they do the rotation of the spine and also the vertebrae, and the red line is the trim line of the brace. In the B section, you will see that there is a strap which is connected from the right side, pulling the body on the left side. And by passing of time, this strap gets pulled more and more. And also with the breath mechanics, it helps the ribs along with the spine to get the pressure and the force to get corrected in order to make the lungs filled with air, and also in the same time the brace gives the opportunity that the ribs, when they inhale, the patient inhales, it has a space where it can open itself. Next slide, please. The third thing, which is very, very important, it's because usually sometimes there are technicians who let's say so, focus more on having only a frontal plane correction. But sometimes that results that having a maximum correction in frontal plane results in having a poor non-harmonic sagittal balance, which should be in a correct or physiological alignment. The third thing, which is that we have to use the brace in order such to have a correct trunk balance in the sagittal plane as it should be in a neutral pelvis inclination. The pelvis inclination must be in accordance with the individual pelvic incidence. And usually when we start the treatment, before starting the physical therapy exercises and also wearing the brace, we do the X-ray, which in sagittal plane, we try to identify how much is the pelvic incidence. And we do that, we find how much is the rate of it, the value of the pelvic incidence. We redo X-ray after we deliver the brace, and after the first follow-up, we do another X-ray, and we compare the pelvic incidence of the before and after the treatment. And we should make sure that it should be in the standards or in the normal range of pelvic incidence according to the patient's age and sex. Next slide, please. Okay, sorry, just one. Can you go back? I need to say something. Okay, so if you see in the picture, the blue one, we have the A curve on the thoracic side. The client has been is already diagnosed with the scoliosis, but scoliosis has given also a thoracic kyphosis, I mean, exaggerating it. So with the brace, we should be able to correct also the kyphosis of the thoracic side, of the thoracic region. And if we go to the C, another client can have scoliosis, which also has the hyperlordotization of the kyphotic thoracic region. And we should also be considering that with the brace, we should correct this hypokyphotization of the thoracic region and make it more physiological kyphosis. If you see in the last picture, we can see in the right one where we have the three views of the patient wearing the brace. We can see that there is the red line shows the physiological and the correct balance of the sagittal plane, which the brace should provide with the patient wearing it. And also, we should not put too much correction of it. So the range of correction that we should achieve from having a brace, the best would be to have a 50% of correction. If let's say so, it's 40 degrees. If we reach to 20 degrees, it's a really good achievement of correction. And keeping in mind, we are not only talking about the frontal plane correction. The sagittal plane correction, it's also very, very important because there are some, as I told before, I have seen some cases which the brace, let's say so, it has been made from people who are doing this job for a long time, and they are focusing only on having the correction in frontal plane, but they have been causing flat back, and there are cases where the client it's not able to do the bending of the trunk. It's reaching only like 20 to 30 degrees of a trunk forward bending of the spine. So next slide, please. I will show you now the cases that I treat in my practice. The first case study, it's a female, 13 years of age. She has been presented with a 37 degrees scope angle with a major thoracic side curve. Research it's 2 plus. Type, I work usually now in Europe, We are working with the RIGO classification. As the previous talkers, they were talking about, there is Lanke and there is King, and there are different. And now the RIGO, Manuel RIGO, Dr. Manuel RIGO classification, in this case that I have, this is a type 1, A1, scoliosis pattern. And we started the treatment of this case with 3D recushion of rays and the personalized physical therapy scoliosis specific exercises. Next slide, please. And after 3 weeks of having the brace on, we usually prescribe the wearing time 21 hours a day, starting by 1 hour the first day of the brace, 2 hours in the second day, 3 hours in the third day, and as by this 1 hour increasing for each day that the patient is wearing the brace. So after 3 weeks, it means that we are wearing the brace for 21 days, and which becomes to 21 hours, and along with the 3 times a day by or max, usually I prescribe 4 times a day, making the physical therapy exercises by 20 minutes and starting early morning, like before going to school, lunchtime when the service user comes back from school, 20 other minutes, evening time, and before sleeping time, it's about like 4 times by 20 minutes physical therapy exercises. So in this case, after the first X-ray of follow-up, we have seen a correction of from 40 degrees. The Cobb angle was showing a 14 degrees. It was reduced by 26 degrees. And the case, we are still on follow-up. She is coming now, I think, in September before school. We'd like to see the patients before starting school time. And after 6 months, we have to redo a brace. We have to redo a X-ray, and we will see the results, how is it going. And until she reaches the RESER 5 or 4 sign, she will be under observation with the brace on. Next slide, please. You can see here the brace on the patient with 3 views, and we use the polypropylene homopolymer 4 and these are the pictures. We can go on the next slide. Yeah, so case study number 2, it's a female, 12 years old. She presented herself with a 34-degree right side thoracic and 30-degree left side lumbar with a Cobb angle and the research sign it's 3+. The type of scoliosis pattern according to RIGO classification, it's an A2 type. And we started the treatment with the 3D RIGO Chanel brace and with the personalized physical therapy specific scoliosis exercises. So we go to the next slide. After 3 weeks of wearing the brace, we did another X-ray with the brace on, and it showed that in the thoracic side, it showed that the curve has gone to 21 degrees, and the lumbar curve has been reduced to 17 degrees. As the previous case, the patient has been wearing the brace for 21 hours a day after 3 weeks. And the follow-up in this case will be every 6 months until she reaches the RESER 5 of the bone growth, of the skeletal growth. Next slide, please. So these are the pictures of the client wearing the brace, and you can see in the same client we use the brace made of polypropylene homopolymer 4 and which is a really good, although I have to say that the 3D Rigo Chanot brace orthotist in Europe, they prescribe is the best as material to make the brace. They prescribe the polypropylene copolymer brace plastic. Felicia, okay, so next slide, please. So the protocols and everyday usage is that we have three types of schedule wearing of the braces. Alternatives is the full time. The patient must wear the brace 20 to 23 hours a day. As I prescribed before, is the first day 1 hour, second day 2 hours, third day 3 hours, and going on. The second schedule is alternative is the part time. The patient must wear the brace 14 to 16 hours per day. And nighttime, the patient wears the brace only at night. So for maintenance, let's say so, and care of the brace and of the patient wearing, he should or she should change the scoliosis brace t-shirt daily, and daily he should be cleaning the brace with a damp cloth. So the next slide, which is, there was another slide that I think you have been putting. No, okay. There is another one because I sent a final reviewed presentation. It's okay. So it's very, very important to know that the latest trend, before we used to have a clashes, let's say so, of professionals inside the team. So doctors were saying no surgery will work. Orthotist will say no brace will work, and physical therapist will say no physical therapy exercises will work. Now we have reached a point that these three lines, if we can prescribe them, before they used to have a distance in here, and now the three lines are slowly getting together and understanding the importance of each member of the rehabilitation team and the treatment team. So let's say so that's my presentation, and the best triangle to defeat scoliosis, if I can say so. Scoliosis is a very, very complex diagnosis, which usually myself has made me really humble towards it. I respect scoliosis because you cannot fight it, and you have to treat it with respect because you can do the best possible of yourself along with the team, but at the end it's very difficult to conquer it. But at the end, my message is that we can defeat scoliosis with a good triangle, which is the patient in front, the medical team on the left side, and the caregiver on the right side of the patient. And in order this triangle to work, to pull down the wall of scoliosis, is that the medical team, along with the patient and along with the caregivers, there should be a triangle of very, very strong one. If one of them is not working, it's not going to be possible. It's the two other members are going to get really exhausted without no result at all. Thank you for your attention, and if there is any question, I'm looking forward to it.
Dear participants, any question from your side? Yes, at least one question there.
Yeah.
Please, Mike.
That was a nice presentation, so thank you. Since you have spoken about the Rigo classification, Rigo Chenio brace, so is there any initial correction that we have to look for in Rigo Chenio with bracing, like the initial correction brace in while the patient is wearing this? So how can I know that this pattern of brace is correct, or I should go for some other pattern?
No, there is, you can find online, and I can type in here. There is this, you can find the, just give me 1 second, because in this presentation you can, it's a really good one, and you can find in it the how we can classify the scoliosis clinical also, and radiological, about the Rigo way, let's say so. Just a second, and I'll send by.
Is it clear your answer question?
No, I will answer to that, but I don't know. I can write. Yeah, just a second. If you can put this one, I'm sending it through the presentation, if it's possible. I'm writing in chat and making it possible. If you can search for what I can see, I don't know. It's Brace Technology thematic series. If you can write it down.
Mr. Arlis, it's fine. She can discuss separately with you.
Okay. Okay. No. So if she can read this, because it's very, very long way of describing if the brace will have a correction. Usually, we do a manual correction on the body, on the trunk of the client, and we see the racer sign, we see the brake, the cob angle, and we see the menarche process. Is it menarche, pre-menarche, or it's on the process of the menarche, and that will give us an estimate of the success of the brace. But also, brace, it's useless if no physical therapy exercises are done.
Yes, sir. Thank
So
you.
you get the point? I mean, like, we have to do the clinical and radiological evaluation, and after that, we can have an estimate of how much the correction should be. But for each brace, if we are able to reach a 50% correction of the cob angle and maintaining a good sagittal balance, physiological one, that is a really good achievement. And the sagittal balance, it's evaluated through the pelvic incidence, which is made from the summing of the sacral slope and the pelvic tilt. I think the doctors know better from it, and we have to do the comparison. How much is the pelvic incidence before treatment, and how much is it after starting the treatment, and the final process where the patient will wear off the brace. And all these 3 numbers that will come out after the treatment will give you an estimate how much successful we have been to keep a physiological shape in sagittal plane of the spine.
Right, sir. Thank you so much.
Any other question?
Any other question?
Any other question?
So there's no question, Arlis.
Okay.
So thank you very much, Arlis, being with us
You're
today.
welcome.
Because
You're
I know
welcome.
it is too early for you
Yeah.
and virtually present with us. So again, thank you for your wonderful and informative presentation.
Thank you. Have a nice day. Best regards to everybody.
So
Have a nice
dear,
day.
So dear participants, now we have small tea break. So tea and coffee organized in canteen for all the participants and for guests and speakers in OPSI room. And we will come back by 12 o'clock. So we have 20-minute break. Okay, so we are running little late. Thank you.
The recording has stopped.
Hello, hello. Hello, hello. And this mic will also work. वो भी work करेगा.
Miss Lakshmi Priya, can you go and check in canteen? Any participants are there?
Cutting slide is not. Slide, full screen slide, it is out of the slide.
Okay, so welcome back to all of you. And again, today, this is the last presentation. And again, we have practical demonstration with the user. And at the end of the CRE, we are going to conduct examination. That is multiple choice question. So you all must appear for examination. If you are not going to attend the examination, you will not receive the certificate from RCI. Okay. So examination is must, and by 1:30 you will receive the question paper on your registered mail. Okay.
This is mandatory. Okay, you
So
have to
this
score
is
70%.
So this is mandatory for all the registered participants who are registered with the RCI.
RCI registered professionals. Others, no issues.
And again, 2 o'clock, this session will get over. So 2 to 3, we have organized lunch for all the participants in canteen.
It is a multiple choice question, right? And it is all from the presentation which is happening. Okay. You got the solution also.
So Nas, can you check the guest speakers? They are in option room. Yeah. Okay, so we'll move to the next topic, that is measurement and casting technique for corrective spinal bracing in scoliosis. And our next speaker is Mr. Sanjay Onam, Assistant General Manager, Rehab Service, Mobility India, and Ms. Minachi, Manager, Piano Training, Mobility India. So just I will brief about both the speaker. Mr. Sanjay Singh has been a driving force behind numerous research endeavors, clinical trial, project management initiatives, and technical and quality control services. His administrative acumen has played a vital role in the efficient functioning of related service in collaboration with both international and national organizations. Currently, Mr. Singh is actively engaged in the development of indigenous design like 3D printing, transtable socket, and various other orthotic devices, contributing to the ongoing innovation and at Mobility India. And our next speaker is Ms. Minachi. She is a RCI certified prosthetist and orthotist, presently working with Mobility India, Bangalore, having more than 18-year work experience. She is mentoring the students for their project research and publication. At present, she is the editorial board member of Journal of Allied Health Science, Rajiv Gandhi University, Health Science, Karnataka, and Secretary of Research Review Committee of Mobility India. Her expertise includes upper limb prosthetics, lower limb orthotics, upper limb orthotics, and spinal orthotics. So please welcome both the speaker, Ms. Minachi and Mr. Sanjay Singh.
Okay, good afternoon, one and all. Good afternoon, one and all. I hope you had a good tea and biscuits in the canteen, so you'll be more energetic to have the next session, right? Yes, let's see that. Because it is going to be a demonstration, more of demonstration. But before starting the demonstration, we will discuss about it, what we are going to do, and so that you will understand what we are going to do on the patient. So our topic is measurement and casting technique for corrective spinal bracing in case of scoliosis. From morning, you have seen many times what is scoliosis, what are the types of scoliosis, how to identify that. You might have heard about bracing also, right? And you have heard how the bracing is going to be effective as a conservative management in case of scoliosis. We are also going to talk about it in little more detail. What is scoliosis? Types of scoliosis, prevalence of scoliosis, when to correct the scoliosis. We will focus more on measurement and casting for the corrective brace, which is a very recent one, as just the previous speaker has talked about the Chinu brace. So we will be focusing more on the Chinu brace, recent trends of spinal bracing in case of scoliosis. Now I will hand it over the mic to Mr. Sanjay.
So as earlier speaker also has said about the scoliosis, scoliosis derived from the Greek word called scolios. Scolios means it is a curve or it is a crook. So he also has, and if we see this scoliosis, it has came to know from 130 AD to 201 AD. By that times, the Dr. Gallion has understand about this scoliosis. They have find out what about this spinal curve is there. So it is long time back. We know that what is this scoliosis is. But as part of the International Society, Scientific Society of Orthopedic Scoliosis Rehabilitation Treatment, they describe that it is a three-dimensional. Earlier speaker also said that one. It's a three-dimensional deformity which is mainly occur in spine and the trunk. So the three-dimensional is that it is on the frontal plane. One is that when you see the kyphosis one, another one is on the lateral side where the scoliosis, and another is when you see on the transverse, which is the rotation. That is the three-dimensional where they said. And it is mainly occur to the healthy children also, and it also progress with the age growth. So mainly, as many of the speaker also said, but for us, it is that if the curve is more than 10 degree and less than 40 degree to 45 degree, that we used to prescribe orthosis. And this orthosis this curve can be higher up to T5 level. So that you can prescribe the sinew brace, which we are going to talk. So I will just say that we have talked about the structural and the non-structural scoliosis, which was talked in the earlier speaker, but I will also have said that transit structural, which is also known as like due to certain small amount of pain, which we occur due to the sciatica, due to some kind of pain on that, we used to temporarily we shift our position, and where the scoliosis has developed, that is known as the transit structural scoliosis. So other scoliosis, I don't need to talk about the non-structural, which occurs due to the postural, due to some compensatory issue, like the structural, due to the idiopathic, which is unknown, congenital, neuromuscular, which is because due to the neuromuscular and other issue. So if we see the prevalence, that the prevalence is around 0.47 to 5.2% of prevalence in scoliosis. But if you see it according to the male and female, so earlier speaker also said about the females are more, so it is 1.5 to 1, and it increased to 3.1. So these data are collected from, which was published from the epidemiology of scoliosis, which was published in the year 2012, December 11. This article was published on that, so this data was taken from that. And seeing all this thing, the progressive used to grow from the 10 degree when it goes to 40, less than 40 degree, it grows to 7.2 to 1 to 1. So in the female 7.2, then male is 1. So which shows that this data shows that the females are having severe progressive rate as compared with the male. So clinical evaluation, when we do this clinical evaluation, the small thing what I will suggest you is that you should follow certain rules, which is known as TOT, talk, observe, touch, then you should do active, resistive, and passive movement. Along with this, what it is shown in the slide, like the trunk asymmetry, which was shown in the earlier, the plumb line test, which the transverse angle to check it, the Adam forward bending test, about the flexibility to check structural or non-structural, where we can correct the scoliosis or not, corpse angle, the rotation, this degree of, the degree of the curvature you can see from the corpse angle. Rib vertebra angles, you can see about the rotation, rises signs to see the maturity. There are different ways where Dr. Arjun has also said about the maturity. How was the maturity? You can see, you can even check on the tone of your voice when you change your voice from the finger, the growth of your axilla, ears, all this, there are different ways to check on that. Then again, pedicles about the rotation, then lateral bending test about the flexibility, then scoliometer, which is also used in the rotational test, where the vertebra rotational test, you can find it out, or else using the scoliometer, you can do the testing. So these are some of the tests what we do. So trunk asymmetry test, where we can find out how much the translation is happening. So when we drop the plumb line from the C7, then it should be on the buttock clips. It should fall on the buttock clip in the normal way. But if it is transverse, that you can know that there is a translation on the spine. Then again, Adam forward bending test as shown earlier also, so I no need to explain. This is to see about the flexibility, how much you will check about the flexibility of the spine. So this is very important when we practice to do about the bracing, because how much pressure you have to provide, you will know all that, and the rotational. These are the things which you can evaluate through the X-ray, like the corpse angle. Corpse angles can be will be evaluated through X-ray. The rib vertebra angles also, along with the razor scale. These three can be evaluated by using your X-ray film. So this is a lateral bending test, which you can see how much bending, how much flexibility is possible, along with this scoliometer, where subendrigi is considered as a normal, but still you can find it out where the bending should be using scoliometer at the peak of your rotation place or a curvature, where when you put your scoliometer, then you will find out that how much degree of rotation is available. So risks of progression, there are certain risks of progression during the S. So many speakers have said about the early identification. If you see the 20 degree of this curvature at the S, there is a chance of 25% chance of increasing. At the S of 10 to 12, then again, if this 20 degree is found out in the S of 13 to 15, then there will be a 10%. Likewise, when it is 16 years, then it is 0. So we talk about, earlier speaker talk about the identification, early identification. These are very important to identify to control this curvature. So like the others are there, like the 20 to 30 degree, the progression chances is 60%. When it comes to the 30 to 60% at the S of 10 to 12, the progression chances is 90. So there is a difference according to that S level, S-wise. So likewise, this risk progression in scoliosis has to be identified at the early stage, and we should start immediate bracing accordingly. These are the braces where from 1869, where orthotics and prosthetics along with orthopedics are prescribing this kind of braces till that. So these are some of the names of the brace where I have shown here. So now I will call Meenakshi to take the next part of this session.
Fine. So far we have seen, and there was one question in the previous session. Somebody has asked about the progression. So you can just have a look in the previous slide. So if the patient is having 30 to 60 degree of Cobb's angle, and at an age of 10 to 12, which is a very common age, you can see the 90% chances of progression is there. So this is the peak time when we have to address this problem, and we have to start, we have to look seriously into the conservative management. Now coming to the classification of scoliosis, already you have seen in previous many presentations, and we are very commonly, we are following the King's classification, where it is from K1 to K5. You can see here all different King classification, how is the spine, and we can see how the CSVL line, which is the center line passing from occiput, center of occiput to center of the gluteal cleft. So we can see here in K1, it is somehow it is passing from the thoracic spine, but it is not crossing through the lumbar spine, and the lumbar spine is having more curvature. So that is more, I will say the lumbar spine is more as compared to the thoracic spine. Similarly, we can see in K2, we can see in K3, K4, and K5. So we can see how the bracing, because there was another question by somebody in the last session, that how will be the brace design which will be given as per the classification, right? So if you see, look for the down image, you know, there are different trim lines of the brace which can be given, and we will take it further in the next slide also, more clear way. So looking into the King classification 1, we can see this is the King classification 1 in the X-ray, which I have just overlapped over the back of the patient, and you can see here how the bracing is done, and you can see the changes, the center line, how it is passing through and through from the occiput to the center of the gluteal cleft, right? So this is how the correction can be achieved in case of King 1. In case of King 2, again, there is a double curve, both crosses the midline. Thoracic curve is larger and stiffer than the lumbar curve in King 2. So we can see the X-ray here, and we can see the changes with the brace. So how the brace will be made, you can see the trim line of the brace and if I compare King 1 and King 2, you can see the proximal trim line of the brace, which is below the axilla here in this side, right? And if I see King 2, it is more on the axilla. So we are trying to apply more unbending force as compared to the King 1, because King 1, the lumbar is more prominent than the thoracic, right? But in King 2, the thoracic is more prominent than the lumbar, and that's how we are giving a unbending force even on the thoracic spine, right? Now we can see a brace in case of King 3, where the thoracic curve crosses the midline and the lumbar curve does not cross the midline. So lumbar curve is not crossing the midline. And when we are making the brace, you can see again the trim line here, which is furthermore high, giving a high pressure on the axilla, right? And trying to apply the unbending forces so that the correction can be achieved. And this is all possible not just because of the Chinu brace, it is also possible because of the cooperation of the patient, because of your skill, how you are going to fabricate it, and a proper follow-up, right? So all different factors which are responsible to get the outcome out of your brace. It's not just the brace, you make it and give it to the patient and you'll get the outcome. You know, you have to look for everything. Now looking into the King 4, there is a long thoracic curve in which L5 is centered. You can see L5 is centered, right, over the sacrum, but L4 tilts into the long thoracic. So we can see the tilting starts from L4, right? L4 means we can see the iliac crest, right? So we can check the iliac crest level, and it is just above vertebra. From there itself, the tilting starts, right? And we can see the brace design here, how we are covering. We are not going much in thoracic, not much higher as compared to the King 3, but yes, we are also taking care of the lower trim line. And King 5, again, if you remember the first presentation, first slide, sorry. Okay, so we can see here the trim line where the thoracic is covered more higher, right? Because we can see here the thoracic spine is very long, right? And we have to give unbending force, which should be just above the apex level in the opposite side. So looking into another classification, which is very commonly nowadays, it is getting followed because of the 3D correction, right? So how we are going to achieve the 3D correction using this Sovereign brace classification, we can see how they have compared this also. So they have S1, S2, S3, S4, S5, which they have compared with the king. So almost if you see here, the first image, second image, third image, fourth and fifth image, you can just match it with the King's classification, and you can see how your center line is passing from occiput to center of the gluteal cleft and the brace design. So very clear cut, you can see the brace design for all different classifications here, which we have already discussed in the King's one also. Now, today we have Master Abhiram with us, and this is the X-ray of him. I just thought to display this so that you will be aware that what case is there and how we are going to have the trim line in the casting. So this is the X-ray of the patient, Master Abhiram, and we will be doing the casting on him. So if we see here, if we drop the center line, we can see the lumbar is more prominent as compared to the thoracic. So that means this falls under which King's classification? Anyone? So this will be King 1, because if I drop the line, we will see the midline will pass through the thoracic, but there is a deviation in the lumbar spine. Okay. Now, coming to the measurement and casting technique, we have the measurement sheet with us, where we are going to take the measurement for the user. And this is just to demonstrate you. This is the measurement form for the Chinu brace. These are the tools which is required. So we have different tools like ML caliper, all you can see the list here, right? So we are going to use the cotton stockinette. We are going to use the POP bandage. We are going to use the measurement tape, calipers, pencil, knife, measure chart, cast scissor, Vaseline, plaster bandages, and cut-off strips. Now coming to the landmarks, it is very important that before taking the measurement, you mark from where to where you are going to take the measurement, right? And you cannot miss that step, and you cannot just go for the measurement. So this is very important that we first mark the landmarks. So if you see, and I'm very happy that many of you are already, they know the basics of the spinal, right? So for them, it will be easy to understand. So you can see here, there is a xiphoid process, which we will do we will palpate each and every landmark on the patient during the process. Then there is a rib cage, iliac crest, ASIS, and pubic symphysis, which we are going to mark in the anterior side mostly. Apart from this, we can also sometimes, if there is a higher curve, we also take a reference of sternal notch. We take a reference of clavicle. We also take a reference of the chest line, right? So we mark all those in the anterior side. Now in the posterior side, you can see there is a spinous process, scapula, iliac crest, PSIS, coccyx, and greater trochanter. These are the main trim line. If you find any kind of asymmetry, definitely it has to be marked, right? So if there is a curve, you have to mark on the apex of the curve, whether it is on the lumbar or it is on the thoracic. So these are the measurements, and it is good to take as much as measurement possible. Why? Because when you are going to fabricate, if you have more number of measurements very close to each other, each landmark, for you, it will be easy to understand how we can make the trim line and how we can give the relief and the pressure at the relevant areas. So we can see all the measurements here. So we are going to take the reference of chest, xiphoid, waist, ASIS, and we will take the reference of trochanter in the posterior side, coccyx. Again, we will take a reference anterior to posterior, right? And then, so you can see this sagittal view where you can see the anterior and you can see the posterior, and you can see how we need to take all the segmental values, not just one overall value, right? So many measurements, which we are going to demonstrate you here. Now coming to the casting options. So how to take the cast? So today we have a very small patient, right? He is just 7-year-old. He is a juvenile idiopathic scoliosis, right? And we were thinking how to take cast for him, because for him to stand for a long time or to sit and give the cast, both will be difficult, right? So we have decided that we will take the cast in standing position, lying position, where we have to take a 2-part AP shell, right? We will make a bi-wall kind of casting. lying cast on a riser frame. So maybe a riser frame, you have heard about, riser sign. Now this is the frame where the casting is done, where the complete elongation and the, other correction components can be taken care. Then the recent technology is also the 3D scan, right? And we avoid taking the cast in sitting, because when you take the cast in sitting, sometimes it is difficult to get the exactness of your impression. Now coming to the consideration which we have to take care during the standing, we have to ask the patient, right? Or we have to observe it. So these are, we have to make sure that the patient is safe. He should not have a fear of falling, right? So that is very important. It is, we have to also ask him to stand, and we have to ask him that how long he can stand without support, right? So that we can make the process accordingly. Then we have to make sure that what instruction we are giving to the patient, he should understand that, right? And he should follow it. We will make sure that we are controlling the flexion, extension, lateral flexion. So all kind of, whatever you have seen, the elements of the scoliosis, right, will be corrected in brace, in casting, so that in brace it will be easy to correct, right? We will also make sure about the leg length discrepancy. We have to make sure that the pelvis is level. In standing, when we take the cast, right, we have to see that we exert the corrective pressure on the patient during taking the plaster impression. So there are two ways. One, we can give the pressure and we can make sure that that he is stable, and to have the patient maintain an optimal position during taking the plaster cast impression, and to make the correction on the plaster positive. So one, we try to make all the correction in the casting. Another process is we check maximum corrected, how much is possible with patient support, right? That much we can correct it in the cast. Remain if what we feel that more correction is required, more opposite forces are required, we can always do the cast correction, right? We can make the cutout, we can apply the forces accordingly, and we can make the changes. You all have seen from morning what is scoliosis and how the 3-point horizontal force system is acting to correct one part of the scoliosis, right? Apart from this, we also apply the derotation forces using the, so Chinu brace, as we have discussed already in the previous session, that it is taking care of all the components, right? So we are correcting the rotation, we are trying to correct this lateral bending, and we are also correcting the flexion deformity in the brace, right? So all three components will be taken care through the Chinu brace. Now you can see the cast evaluation, right? So we have taken the image of frontal plane and the sagittal plane, and you can see once you take the cast out, so once you get the negative cast, right, we have to also assess the negative cast to further go for the next step. So if we see that there is not an even surface, we may have to add the wedges, we may have to add the wedges at the down to make the pelvis symmetrical, right, to get this alignment, right? So we have to see that alignment is very appropriate, and we will also see the alignment in the sagittal view. So it should pass from the mid-axilla and mid-trochanteric line. So we will follow this during the negative cast production, and same we will replicate in making the negative mold, right? And later, whatever the remain will be there, we will take care during the positive mold. So you can see here in sagittal plane, the plumb line runs through the axilla to the hip joint. And in the frontal plane, the plumb line is only the rough guideline. So we just see the center line is appropriately from the center of the occiput to the center of the gluteal cleft. Okay, so there are different brace design you have seen in previous slides also, right? Which can be prescribed, and it all depends on the individual choice, right? And the type of curve, the type of flexibility, whether you want to go for a very rigid brace or you want to go for a dynamic brace, right? It all depends on that. And there are many options. There is no hard and fast rule that only one brace can be prescribed. There are some braces which is mainly called as nighttime brace, right? Which is very much commonly given to the patient who are very young age. I'll say just in early intervention, if we find that at the age of 6, 7, 8, 10. So it is good to also go for a nighttime brace along with the daytime brace, right? Which will have more effectiveness in correction of the scoliosis. So one patient can be given even more than one brace, right? So looking into the biomechanics, how these braces acts, I'll not go much into this part, right? So you can see here, if there is a double curve, right? Chino brace is mainly given, it's very much effective when there is a double curve, right? So if we look into this, right, we try to correct in segments. So we try to cover the lumbar part, and we also try to cover the thoracic part. And there we are applying 3.4 system, one for the lumbar apex and one for the thoracic apex. And this is called as triangulation of forces, where the forces are applied in two triangles and there are only 4 points of contact. So you can see this white patches, 1, 2, 3, 4. So only 4 points of contact is there, but actually it is applying 3.4 system to correct the deformity. Now we can see X-ray of the patient and X-ray with the brace. So with and without the brace. So how the Chino brace is, mostly it is very much effective if it is given in an appropriate age with a appropriate curve, right? So if we see, if it is taken care before the age of puberty and if it is given in a range of 40 to 45 degree of curve, right, it is very much effective. But as we have seen in previous slide also, there is a risk of progression for different age, different curve, right? So that we have to look into, and we have to give the brace. We have to do the proper follow-up for that. Now, just going through the recents, because today main topic is measurement and casting. We are not going to cover this, but since time is changing, there are many things which is upcoming, right? And we should be aware of it. So it's not just the plaster cast which can be taken. Sometimes it is difficult for patient, and maybe to adopt the technology, we also use different methods, right? So there are CAD/CAM method which is available, which can be also used to fabricate the device. And with this CAD/CAM method, we can also make the digital library of the patient, right? And whenever he or she comes for the follow-up, we can, do the manipulation in that itself. So every time you need not to take the cast and make patient, bear you for 1 hour for casting, right? So this is very good method to maintain the library, digital library of the patient, but unfortunately it is not so popular at present. So there are different robotic braces also which is available, which you can see here, like people has to do the 3D scan. Then again, it will be modified. Then design of the brace will be decided. As per the previous King classification, you have seen the brace design. Similarly here also, and these all are dynamic braces, right? It will correct the deformity in all 3-dimensional plane, right? So, and then fabrication and calibration. So calibration is must. Again, this is not very popular, but yes, this is all under the research and it's in progress. Again, this is also, you can see very dynamic brace, right? Where all the different parts can be adjusted. So it is not like it is a universal model. We can change the pressure according to the requirement, and this can be fitted to the patients. Again, you can see here, this is a 3D molding, 3D printed device, which is a dynamic device, streamline, and the material is different. Material is more smart material, and it is very light in weight, right? So all different materials can be used. There are some flexible orthoses, like you can see here. This is more dynamic orthosis, which can be given in case of adult scoliosis, right? So the same brace, just about how it is working. So we can see all the components of this brace, how the forces are acting at different places to correct the deformity in case of, or to maintain the deformity in case of adult scoliosis. These are the references. And I'll just play one short video to give you the idea about what we are going to do now. So we are also going to do the same process now. So this was a high curve. That is why I'm also marking the sternal notch. Just trying to mark the line from center of occiput to center of gluteal cleft. So after landmarking, we are going to take the measurement, which we will do now on the user. And then followed with casting. So once we reach till just above the iliac crest, we first start giving the pressure at the iliac crest so that the pelvic symmetry can be properly maintained in the cast. And since there was a high thoracic curve, so we are covering complete thoracic region. And just to get a very good negative cast, we are also covering the shoulder so that, in one stretch we can cut it and we can get a negative cast. So no need to keep reinforcing on the proximal part of it. And we have tried to achieve the active correction in this casting, right? And rest we have done the modification in the negative cast. Okay, so till here we are going to cover now on the user, and rest part will be taken care maybe hopefully in the next CRE. Okay, so already we are getting late, and without any further delay, we will start working with the user. Later, we need to check the cast alignment. So we will check the cast alignment on the negative cast. Yeah, and that's it. Thank you. Okay. Okay, so now we are starting with the landmarking. And it is very important that before working with the user, you need to instruct him what you're going to do on him, right? And you need to take a permission or a consent from him, right? Since he is less than 18, it is important that we have a consent with the parents, right? And then we start working on the patient. So we have already done that procedure. And now we are going to take the, we are going to mark the landmark and take the measurement on him along with the casting. So as you have already seen in presentation, the landmark which we are going to mark in the anterior side, we are going to mark the iliac crest, right? All of you can palpate on your body if you want, right? So you can palpate the iliac crest. We will mark the ASIS in the anterior side. We will mark the umbilicus. We will mark the umbilicus. We will mark pubic symphysis, right? And in lateral side, we will mark the greater trochanter. We will mark the waist level. So you can see how we are performing this, right? We are trying to make him bend in one side and mark, and similarly for the opposite side, right? So for him, we have already checked, we have done the screening of the patient before this CRE program, right? And there is not leg length discrepancy, which is very less and which can be taken care through the brace. So we are not going to take care of the lower limb part right now because it is not required in this case. Yeah. So we have marked the axilla, we have marked the chest line, right? And we will also mark the sternal notch. We have marked the clavicle. We are trying to mark it will come out, all the muscles will bulge out. So there was a method that you remove the complete bulging of the muscles, right, to create the intracavitary pressure, right? And that's how the 3.4 system was acting in previous days using the Boston brace, right? But now that the technique has changed, we are not removing it fully, and we are not giving a direct intracavitary pressure. So the Chinu brace, which you have heard or you are listening from the morning, is actually an overlap brace, right, which is having an anterior opening, right? With the help of Velcro, it will be closed, right? And that gives the pressure only to the specific area, only to the area where the point pressure is required. It is not giving an overall pressure. So if I see the Chinu brace, it is not a complete total contact brace. There is a partial total contact. In the sense, there is a breathing space within the brace where the patient can move themselves inside the brace to achieve the maximum correction, right? So that's how the Chinu brace works, and that is a dynamic brace because the patient can breathe inside the brace and they can get the active correction inside the brace, right? So this is the difference in methods, the previous Boston and the now Chinu, right? And as we have discussed before, that effectiveness of brace is not just by making a brace. It is very much important that the instruction what you're giving to the patient, the weaning period, how long he or she should wear it, right, in a day, right, and how frequently they should have a follow-up, right? So the follow-up and radiography, which is must, and it is good to have the radiographs if the patient is very young, at least within a 6-month of period, right? So that you can do a proper follow-up and you can change the brace if it is required, or you can change the pressure points in the brace, existing brace, if it is required, right? So that way we can achieve better correction rather than just giving one brace and thinking that the patient will get the correction, right? So very important is the follow-up, right, and the X-ray. So always instruct your patient to have a follow-up in 2 to 3 months, right, where you can manually check it. And X-ray can be also taken in a range of 6 months at least. So this is a juvenile idiopathic case where you can see he is having a long way to go with this scoliosis, right? So if you don't take care of this in the beginning, the curve will progress. As you have seen, the risk of progression, right, that is very much high in case of young age, in case of age of 7 to 8 years, right? So to control that, he has to be in brace and he has to be maximum in brace. Minimum 18 hours is required that he should be there in the brace. Otherwise, the brace will not work, right? Shoulder cover किए हैं, लेकिन यहाँ पे कुछ है नहीं, वो strip था, ये strip insert कर दो, कट करो उसको, नहीं बनेगा, ड्राई हो जाएगा, strip insert, strip डालो, strip डालो. How do you know? Wheelchair patient. So wheelchair patient, we can do the casting in lying position. Yes. So we can make him lie in the sideline position or maybe also in the supine position, and we can take the cast in 2 shell. So we can take one side cast, turn him, and take another side cast. Yeah. But I think we take the measurement when the hip is flexed, right? And that's fine. Yeah, that will be all right. And when he will lie, we can take the vertical measurements. So that's not a problem. So if we have to take the LL and AP measurement, we can even take in sitting, right? And the overall, the length measurement, we can check when he is in a lying position. That can be managed. Because many spinal cord injury patient is given not with the corrective braces, with the TLSOs, right? For the back support. Yes. So we take the cast, correct. Correct. So we take the cast in lying position. So I'm not talking about the corrective brace. Corrective brace is only given when there is a flexible spine, right? That you have seen in the previous session by the doctor and by the physiotherapist, right? So this corrective brace is only given till the time when the spine is flexible, right? She is talking about the case where it is a paralytic case and the patient has to be braced to have the back support, so that when he sits on the wheelchair for a long time, his back will be supported. So all of you, many of you know about the molded seat, which is a very common type of support, which is given along with the wheelchair for them to sit for a longer time. Yes, so we make the molded seat for them. Instead of making a separate brace, sometimes we make it, attach it in the wheelchair.
Display.
From this side or this side, any other questions is there so that we have to address for you? Because some question has come up that Zygmunt pressure has to be given or not, because Zygmunt is not used for the correction. It is used to have use in the correction of rotational only. It supports it because you cannot give a lot of pressure on the Zygmunt area because it is just next to your what near to all your lungs and all these things. So it will have problem.
Okay, so any other questions? Many questions we have discussed during the process. If still you have any questions, you can ask. Yes, Mike, please.
All the classifications that you have said for kings and all the blueprints that you have given is basically for AAS patients.
Yes.
But we can't expect the king classification curves to be seen in.
This is mainly for the corrective scoliosis.
Yes, for so if that is the case, even that patient that we saw now is not an AAS patient, so we cannot.
No, he is a AIS patient. Yeah.
Not an adolescent, he's a juvenile.
He is a juvenile, but it is a idiopathic scoliosis.
Okay.
Not
So-
an AIS, he is a juvenile idiopathic scoliosis.
Somewhere in
Yeah,
idiopathy.
yeah.
So, but I can't expect this blueprint or whatever the King's classification for any other kind of scoliosis like congenital.
No,
or
but this is also idiopathic scoliosis, which is flexible, which can be correctable,
Okay.
right? So we will follow the same
So
principle.
is
here.
that okay if I apply these curves and principles on a neuromuscular or congenital?
No, not
scoliosis?
always, not always, not
Mhm.
always. We have to see the age of the patient, we have to see the skeletal maturity, we have to see the flexibility of the spine, curve pattern, and based on that, we have to decide what.
This is a curiosity doubt. So is there any other classification or a base models that have developed for neuromuscular or congenital cases?
See, for neuromuscular, if we look into the basic principle of bracing, right? It is not always for the correction. Sometimes we give the brace only for the support or the prevention. So in those cases, without following the corrective principles, we will just go for the supportive bracing. As she has asked the question of paralytic spine, where I suggested that we can go for TLSO, but it will not have a purpose of correction. It will be just given to maintain the maximum optimum upright posture. That's it. Okay, thank you.
Most of the prescribe only the positional brace because most of the neuromuscular you will not able to do the correction because it involves muscular and neurological issues. So you will not achieve until and unless these two issues are addressed. So
What if it's not a
I will suggest
progressive disease?
so that's why you have to go with the positioning muscular, neuromuscular, that the bending will be more. So his will be compressing all the internal organs and all. So when you try to position it properly, that the function of your lungs will be normal, heart will be proper, so that should be allowed. And at the same time, you have to control the pelvis region, where in any spinal brace, pelvis is one of the foundation which is very much important. You have to consider. So that has to be done so that you can control the bending. I can support so that he can sit erect and do some kind of small daily activities without any support. All these things, and even with the wheelchair, with some question has asked that even in doing the wheelchair, along with the spinal brace, your pelvis support is very much important to control the spine. Because if you move, if you move your pelvis posterior, what happens? The whole spine come forwards. Then to get the center of gravity, you try to bring it back. Then you get the lordosis. So when you go it, your spine goes anteriorly, the whole spine goes back. The pelvis goes anteriorly, spine goes back. Then you try to get the center of line or gravity. Then you commit, then it becomes kyphosis. So you have to play important role while designing your spinal brace. So how you do the trim line to maintain that pelvis into the neutral position. That is one of the important way when you design orthosis. Yes.
While we are going to correct the scoliosis and all the things in the upper trunk movement, so there is a respiratory movement in the chest, the trunk movement.
Yes.
What if we arrest that? What happens to? Please explain, sir. What happens to respiratory, the infections and the, if it is there, and how much the housing we have to place for the trunk?
Okay.
upper trunk.
We should not erase respiratory movement.
For the pressures, we have to
Yes.
point the pressure.
First, we should understand how the trunk function.
Okay.
Yes.
The trunk function is in two ways. The upper portion of the trunks will be function in the vertical way. It opens in the vertical way, and the lower portion of the trunks, which is opening area, will expand in the horizontal way.
Okay, just to answer, just to add to this, sir, I have a mic. Okay, we take the measurement in breathe in and breathe out to take care of this part, right? So we take both the measurements and we maintain the space accordingly inside the brace so that the patient will not have any kind of breathing issues.
On the positive mode,
Yeah, it is on the negative mode. After doing the modification, we produce a positive mode.
But you should not tightly, we should open it on the face area where you should have the breathing. So like when you do the Sinu brace, and if you compare with the Boston brace, there is two important things. Is that in Boston brace, you have to do a lot of breathing exercise where physiotherapy has to teach them that how to do the corrective brace. This is because of the breathing, how the pressure applied on the brace. Where in Sinu, it is different again. You have to do breathing as well as with the correction of that pressure with the rotational and all. So that's there on that.
So you
should not restrict your anterior portion of your chest area where the heart is there. So you should not restrict at all. So if you open it or you have a room there. When you design it, you add the material so that there should not be any pressure on that area.
He's growing.
You should give the room.
So there are many questions which is coming from this side also. So there is a question that, how soon we have to change the brace. So it all depends on how soon the child grows. Okay. We cannot have a predetermined months or the, year to change the brace. We have to see how the child is growing, and based on his growth, we have to decide the change of the brace. So till the time we can do the modification in the same brace, we can do it. But when the force system, the point of contact will change with his growth, we have to change the brace, right? Just here one.
Normally you will find in 6 to 9 months time. 6 to 9 months time is the time where you find the changes, so you can change it during that time.
So you can see here in this, we have just tried to show you the alignment, but right now I can see it's going back. So we need to add the wedges in the posterior, and we need to make this vertical, right? Then only when you will fill it, you will get a good negative mold to further produce the product like brace, right? So we have to give the wedge, which I have shown in my presentation, right? So we have to give the wedge there to make it more vertical, right? So this is just one addition to that. Any further question?
Yes, ma'am. One question that why we come from Boston brace to Chenu brace. As we know, in Boston brace, we are giving the intracapital cavity pressure. Because of that, the lumbar lordosis is decreasing, and because of that, the kyphosis is also decreasing. Because the scoliosis have a hypokyphosis also there in scoliosis. So if you see that this condition, there is a lordosis is there as well as a kyphosis is there. So if you will prescribe Boston brace in this case, it will reduce both the lordosis as well as the kyphosis.
Okay.
So whether the Chenu brace is which
Okay,
one will
just to answer to your question, how we do the lumbar lordosis, it is all done with the positioning one, right? And also we can do it while producing the positive mold, right? So right now he was not that much comfortable, and we took the cast completely in standing. If we make the hip and knee flexed, right? And maintain the position of the lumbar spine, stabilize the lumbar spine, the lordosis will automatically reduce, which we couldn't able to do in this case. Okay, so this is what I said. Every case is different. Every patient is different, right? Does not mean that we have to switch to another brace. Okay, and if you're talking about the hypokyphosis, right, here we can always do the different modifications. So if there is a kyphotic condition, right, we can always take care of the flexion of the spine in the brace while doing the modification, right? To control the vertebral rotation, we can also extend the thoracic part, right, to apply the derotation forces, right? So that all possibilities are there. Boston brace, if I compare the Boston brace and the Chenu brace, as you recommended, Boston brace is basically a rigid brace. A rigid does not mean that rigid because of the material. It is about the feet discussed that there are only points which is contacting the apex, only the points which is giving the pressure. And there are the hollow surface where the patient can breathe and cannot have any kind of obstacle in the breathing issue function, right? So because of that, this brace is a dynamic, where the Boston brace is basically a very rigid brace, right? So now the time is changing. Patient also want comfort, and with comfort, if we are getting the correction, why not? Why to go for a rigid brace? Okay.
Level of correction is also there. Also, this goes up to whereas this new brace it goes up to T5. So that also you need to see how where your curvature is.
So you can see in sagittal view also, here since it is a lordotic spine, you can see the laser light, which is the alignment you can see, which is coming anterior, right? As soon as I give a wedge and bring it in a normal corrected position, I will get a correction of the lordotic posture also, right? So that all is possible, you know, in the modification and in the cast rectification, which is not a topic of this CRE. Definitely we will see in future, right? If the time permits and if it is a 2 days or 3 days program, right? We can continue with the further steps. Yeah. Sorry. Any other questions? Yeah. Mike, please.
With the braces, whether the child can lead the normal life? Whether the child can lead the normal life or any restrictions is there?
See, I don't know how much you are aware of scoliosis as a disability. If I look into the scoliosis, right, which is correctable and not having very severe angulation, scoliosis is only considered as 10% of disability. If you go to the disability index, right? So it's not a very severe disability where the patient cannot lead a normal life, right? Yes, he is doing everything. He is doing everything. But with brace, it will be more functional. Yes, very much. Because, yeah, with brace. Because the brace is made with a plastic material, right? So there is no harm. And if we give a dynamic brace, yes, why not? Yeah.
Any other question? Please raise your hand.
Ask the child how he's feeling. Thank him for the effort.
Okay, so I think any other further questions? No questions. So I would like to thank Abhiram and his parents for coming here today and supporting us in doing this hands-on demonstration. Otherwise, it's very difficult that you get a patient on the right time. He has come here for screening before, and then he has come for today. So thank you so much. And thanks to all the participants. And I'll just hand it over to the organizer.
Thank you, Meenakshi. Thank you, Sanjay Singh. I think it was very interesting and informative presentation. And again, this practical demonstration done with the live model is very, very knowledgeable, I think, for all of us. So among with us, Rumela Joseph ma'am is present, our past president of Mobility India. So I welcome you, ma'am. And I like to call both the speaker on stage. And I would like to invite Rumela Joseph ma'am to come forward and give the memento to our speaker, Ms. Meenakshi and Mr. Sanjay Singh as a token of appreciation. Thank you. Thank you, ma'am. So now we reached at the end of the program. And dear participants who are registered with RCI and non-RCI registered, you will receive that questionnaire link in your registered mail ID by 1:30. So you can check your mail and you need to appear that examination. No, WhatsApp we have not shared. So if you are some of them not able to access, check your mail, registered mail ID. And yes, can you check it? It can be, if you have the link, some of the participants can be shared through WhatsApp. Okay, checking, rechecking. Yeah. So within 5 minutes, you will receive the link of questionnaire. Yes. Okay. So now at the end of the program, okay, so I like to thank our all speaker, Dr. Prashant Inna, Dr. Arjun Kumar, Dr. Mayur Kudba, Mr. Sanjay Singh, Mr. Binachi, once again for their wonderful presentation and for sharing the expertise and insight with us. They have given us a lot to think about and to apply to our on-field industry. Let us give a big round of applause to all the speakers. I'd like to thank all the participants, alumni, graduates, students of Mobility India for your active and enthusiastic participation and contribution. In addition, I like to thank all our board members, executive director, academic and technical director for their support, and all the supporting department who are directly involved or indirectly involved to make this program successful. So we'd like to thank all, each and every department. And we should not forget to thank our service user. We called and he is available with us from morning. So we need to thanks to our service user for their contribution, for their support, and for our learning. So once again, thank you all participants. Thank you.